Hello everyone. All right. Yeah. So good evening everyone. Welcome to this one-shot previous year topic revision sessions. So your FMGE examination is going to be conducted in January. So this is a session from all of our faculty at DBMCI so that you can effectively revise for FMGE. And good evening everyone. Just give me a moment. Yeah, one second. Yeah. So this is basically so that you can effectively revise for your FMGE exams just prior. Obviously, revision can be a daunting task for a lot of people. So this is to help you guys revise properly and effectively as far as your exams is concerned. Okay. Now, coming to your FMGE, some important topics as far as FMGE is concerned. Some important topics as far as FMGE is concerned. These include your growth and development. These include your growth and development. And by development, particularly your milestones are very important. Particularly your milestones. Your milestones are very important. You can always expect 1 or 2 questions coming from milestones. And obviously growth is also very important. Apart from this, all your vitamin deficiency and malnutrition. Nutrition as a topic in its whole is very important. All right. Nutrition as a topic as a whole is very important. This includes your vitamins. And this includes your malnutrition, in particular your SAM. Just one second. Yeah, sorry for the disturbance. This includes your malnutrition. This includes your vitamins, deficiencies of important vitamins as far as your exam is concerned. Apart from this, a little bit of genetics also is important. Questions related to Nunan syndrome have been asked. Questions related to Turner syndrome have been asked. So those genetic disorders, those syndromic disorders, those are important. Apart from that, your IMNCI. Be it dehydration or be it the pneumonia. The management of dehydration or the management of pneumonia, again, very important. Then as far as your cardio is concerned, in the congenital heart diseases, if you just have to do one topic, in fact 90% or more, I will say in fact 100% of your questions have just come from this one topic that is your Tetralogy of Fallot. All right, Tetralogy of Fallot. And apart from this, a little bit of overlap between pediatrics and surgery, your GI surgical disorders. Particularly your infantile hypertrophic pyloric stenosis. This is an overlap between surgery and pediatrics. These are, again, very important as far as your FMGE exam is concerned. Very important apart from your FMGE exam is concerned. Then obviously there are a lot of overlap topics which actually probably would have been covered in pathology as well, would have been covered in medicine as well. Your topics from hematology, all right, your leukemias, your thalassemias and your anemias. This is something which is covered in in some form in pathology, it's covered in some form in physiology, it's covered in some form in medicine. Something which is so widespread across all the subjects obviously becomes very important. So I'm not going to write that down here. These are the topics that we'll be covering, broad topics that we'll be covering today. All right, these are the broad topics that we'll be covering today. All right. So someone asked me, how's my health? Thank you, Rishi. Thank you for asking that. I'm much better right now. The asthma, for those who don't know, I have asthma. That asthma has become better now thanks to the Delhi pollution. It was bad, but now I am much better. All right. On that note, let's begin our session for today. Wishing you all the very best for your for the upcoming new year. A happy new year to every one of you. In 2 days' time, we'll be witnessing 2025, and I hope that everyone amongst you who's watching this session passes. All right. Let's hope for a 100% pass rate. Obviously, let's hope for a 100% pass rate as far as this FMGE exam is concerned. I hope each and every single one of you who's watching this session ends up passing their FMGE exam. All right. With this, let's begin. Let's first discuss growth. In growth, we'll be discussing about weight, length, and height circumference. We'll be discussing about the weight of the baby. We'll be discussing about the length of the baby, and we'll be discussing about the head circumference of the baby. Right. Now, as far as the weight of the baby is concerned, we all know that at birth, the birth weight of a baby is around 3 kgs. The average birth weight is around it is around 3 kgs. Let's consider this X. Let's consider this birth weight as X. Let's consider this birth weight as what? Let's consider this birth weight as X. Alright, let's consider this birth weight as X. Now, in 5 months time, this birth weight will double. It will what? Double. So 3 kg will become what? It will become 6 kgs. 3 kgs will become what? It will become 6 kgs. So the birth weight doubles. In 1 year times, the birth weight is going to triple. It will become 3x. That is 9 kgs. That is 9 kgs. In 2 years, it will become 4 times. 4x. That is 12 kgs. In 3 years times, it will become 5x. That is 15 kgs. In 5 years time, it will become 6x. That is 18 kg. In 7 years times, it will become 7x. It will become 7x. That is 21 kgs. And in 10 years time, it will become 10 times the birth weight. That is 30 kg. Alright. So doubling in 5 months, tripling in 1 year. Now, when we discuss about length, as far as length of the baby is concerned, at birth, the length of the baby is around 50 centimeter. At birth, the length of the baby is around 50 centimeter. In the first year of life, the baby is going to gain 25 centimeter of length. So baby will gain what? 25 centimeter of length. So this will become what? This will become 75 centimeter. This will become what? This will become 75 centimeter. In the next year, from the first to the second year, baby is going to gain half of what it gained in the first year. So in the first year, the baby gained 25 centimeter. In the next year, baby is only going to gain what? 12.5 centimeter. That is around 12 to 13 centimeter. So in the next year, baby is going to gain around 12 to 13 centimeter. So the height or the length at 2 years of age is going to be what? It's going to be 87 centimeter. From 2 years till 4 years of age, baby is going to gain again half of what it gained in the previous year. So baby was gaining 12 to 13 centimeter. Now the baby will gain what? Baby will gain 6 to 7 centimeter per year. Baby will gain what? Baby will gain 6 to 7 centimeter per year. Alright. So 87 centimeter at 2 years, 87 plus 6, 93 centimeter at 3 years, another 6 to 7 centimeter, so that by the time child reaches 4 years of age, the length of the baby is going to be what? It's going to be 100 centimeter. It's going to be 100 centimeter. If you look at this closely, can you realize, do you understand that the birth length was 50 centimeter? This 50 centimeter has doubled. It has become what? It has become 2 times the birth weight at 4 years of age. It has become 2 times the birth length. I'm sorry. It has become 2 times the birth length at 4 years of age. So as far as weight is concerned, if you take weight, the birth weight doubles in 5 months. The birth weight will double in 5 months. But the birth length takes 4 years to double. It takes how much time? It takes 4 years to double. Alright. After 4 years, baby is going to gain height at 6 centimeter per year. Baby is going to gain height at 6 centimeter per year till puberty. So sorry, again. Sorry for this. Just 1 second. This must be some problem. 1 second. Yeah, again it's back. Yeah. So at 4 years of age, baby is going to be what? Baby is going to be 100 centimeter. Beyond 4 years, baby is going to gain 6 centimeter per year. Baby is going to gain 6 centimeter per year till puberty. Okay, till puberty, baby is going to gain 6 centimeter per year. Alright. Now, there are some simple one-liners which have been asked in previous exams, not in FMG, but they have been asked recently in NEET PG and INI-CET, so they can be repeated in your FMG as well if we go by the trends. Alright, so weight doubling. We discussed weight will double in 5 months. Weight will double in 5 months. It will triple in what? If we look at this table, it triples 3x the birth weight occurs at 1 year of age. So weight will triple in what? Weight will triple in 1 year. It triples in 1 year. It triples in 1 year. Height doubles. So we saw height takes 4 years to double. Height will double in 4 years. Height will double in 4 years. Height will double in 4 years. There was a question asked previously once that height is half the adult height. A child height is half the adult height when? So normal adult height is around 170 centimeter. So half the adult height is going to be what? It's going to be 170 into 50%. That is half. What is going to be the half the adult height? It's going to be around 85 centimeter. It's going to be what? 85 centimeter. So when was the child 85 centimeter? Child was 85 centimeter at around 2 years of age. Around 2 years. Slightly prior to 2 years. Slightly prior to 2 years. So child is half the adult height. Child is half the adult height at 2 years of age. At 2 years of age. Alright, child is half the adult height at 2 years of age. So this is as far as your weight and length is concerned. Now we come to head circumference. Now we come to head circumference. This is your head. This is your head circumference, right? At birth, the head circumference, is around 33 to 34 centimeter. It is around 33 to 34 centimeter. Okay. During the first 3 months, of life, that is, baby is going to gain head circumference at 2 centimeter per month. Baby will gain head circumference at 2 centimeter per month. Okay. Now, from the 4th to 6th month, baby is going to gain head circumference at 1 centimeter per month. At 1 centimeter per month. And from 7th to 12th month, those 6 months, another 7th, 8th, 9th, 10th, 11th, 12th month, baby is going to gain head circumference at 0.5 centimeter per month. It's going to gain head circumference at 0.5 centimeter per month. So the absolute increase, if I talk about the absolute increase in head circumference, during the first 3 months, the absolute increase is going to be what? It's going to be 2 into 3. It's going to be what? It's going to be 2 into 3, that is 6 centimeter. From the 4th to 6th month, it's going to be what? 1 into 3. 1 centimeter per month, 3 months. So 1 centimeter per month, 3 months, it's going to be 3 centimeter. And in the next 6 months, it's going to be 0.5 into 6, another 3 centimeter. So in the entire first year, baby would have gained how much head circumference? 6 plus 3 plus 3. Baby would have gained 12 centimeter of head circumference. So if the birth head circumference was 34 centimeter, at 1 year of age, it would be what? It would be 46 centimeter. It would be 46 centimeter. Okay. And in the next 1 year, from 1 to 2 year, baby gains only 2 centimeter of head circumference. Baby gains only what? Baby gains only 2 centimeter of head circumference. So it will become what? It will become 48 centimeter. It will become 48 centimeter. Now a question to you guys, for those who are watching the session live, what is going to be the adult head circumference? Can anyone take a guess? What is the adult head circumference? Can anyone tell me in the comment section what is the adult head circumference? What is the adult head circumference? Can anyone tell me what is the adult head circumference? What is the adult head circumference? So Ajay Pratap is correct. The adult head circumference is 53 centimeter. The adult head circumference is what? The adult head circumference is 53 centimeter. Alright. Now, 48 of 53 is what? If we do 48 by 53, this will be around 90%. So can we say a child has gained 90% of adult head circumference? A child has gained 90% of adult head circumference by 2 years of age. So write down the statement that a child has gained 90% of adult head circumference by 2 years of age. Okay, a child has gained 90% of adult head circumference by 2 years of age. Okay, very important statement, can be asked. Alright, a child has gained 90% of adult head circumference by 2 years of age. Coming to some important growth curves, these are some important growth curves of some important tissues. Okay, the first growth curve, if we look at the first growth curve, this growth curve, can you see that the maximum 90% of the growth has already occurred by 2 years of age? 90% of the growth has already occurred by 2 years of age, and then it's a plateau. This is going to be nothing but your head circumference, and head circumference is what? Your brain. Alright, so this growth curve is what? This is nothing but your brain. This is nothing but your brain or CNS. So this growth curve, a growth curve which initially is a very fast uprise and then a plateau, is going to be your brain or CNS. If you look at this growth curve, the maximum growth has occurred between 4 and 8 years. the maximum growth has occurred between 4 and 8 years. All right. This tissue is what? This is your lymphoid tissue. This is your lymphoid tissue. This is your lymphoid tissue. Okay. This is your lymphoid tissue. If I look at this growth curve, this growth curve initially is very fast. Initially, there is a very fast growth. Then there is a little bit of plateau. And uske baad, after that, there is another fast growth. Okay. This is what? This is your length. This is your length or height. In the initial 1 year, 25 centimeter, 12 centimeter. Then 6 centimeter till what? Till puberty. After puberty, again you are going to have what? Again you are going to have your growth spurt. In puberty, we all know there is what? There is growth spurt. So this is basically your length or height. This is basically your length or height. This is how length or height is going to behave. And length and height is made up of what? It is your skeletal system. So as far as tissue is concerned, this is going to be your skeletal tissue. This is going to be your skeletal tissue or somatic tissue. This is going to be skeletal or somatic tissue. This is going to be your skeletal or somatic tissue, right? And the last growth curve that I'll show you, this growth curve. Initially, it is very silent. No growth is occurring. And then around puberty, suddenly there is a lot of growth. At around puberty, suddenly there is a lot of growth. So this is going to be what? This is going to be your testes and ovaries, your gonads, right? This is going to be your gonads. That is your testes and ovaries. All right. So these are some important growth curves. Now coming to puberty. Now, sequence of puberty is very important, has been asked multiple times. The sequence of puberty is very important. All right. So the sequence of puberty as far as females are concerned, is, in fact, the sequence of puberty both in females and males, you can easily remember by the mnemonic TPM. This is same as far as males and females is concerned. Let's see that. In females, the first sign of puberty is Thylarch. It is what? It is Thylarch. That is breast development. Okay. Thylarch is followed by pubarch. That is the development of your pubic hair. And pubarch is followed by menarche. That is the beginning of your menstrual cycle. Just prior to menarche, slightly prior to menarche, girls will have their growth spurt. Okay, so this is the sequence of puberty as far as females are concerned. Thylarch, pubarch, and menarche. Just prior to menarche, growth spurt. As far as males are concerned, again same. Mnemonic is what? The same. TPM. Males, obviously the males won't have breast development. They won't have Thylarch. Males will have what? They will have increase in testicular size. They will have testicular enlargement. And this is the first sign of puberty in males. Testicular enlargement will be followed by pubarch and penile growth as far as males are concerned. This will again be followed by pubarch, that is pubic hair, and penile growth as far as males are concerned. And then it will be followed by what? It will be followed by what I like to call manly changes. This is from the mnemonics point of view. What are these manly changes? The development of your beard, the development of your voice change. These are the manly changes that I'm talking about. So your beard growth, and the voice change as far as males are concerned, this is what will happen as far as males are concerned. TPM again stays the same. Testicular enlargement, pubarch and penile growth, and then the manly changes, the beard growth and the voice change. And just prior to this beard growth and voice, males also will have their growth spurts. Males also just prior, a little bit prior to these manly changes, males also will have their growth spurt. So this is how you can remember the sequence of puberty as far as males and females are concerned. TPM. Females, TPM is Thylarch, pubarch, menarche. Males, TPM is testicular enlargement, pubarch and penile growth, and the manly changes, the beard growth and the voice change. Coming to the Tanner staging as far as males and females are concerned. So Tanner staging is also called sexual maturity rating staging. It is also called sexual maturity. It's also called sexual maturity rating or SMR staging. Okay, it's also called SMR staging. So coming to the Tanner staging as far as males are concerned, so Tanner staging is Tanner stage 1, 2, 3, 4 and 5. Always remember, Tanner stage 1 will be prepubertal, that is prior to puberty, and Tanner stage 5 is the final stage. Tanner stage 5 is the final stage, so that will be the adult pattern. So that will be the adult pattern. So Tanner stage 1 is what? Tanner stage 1 is prepubertal. Tanner stage 1 is prepubertal, prior to puberty, and Tanner stage 5 will always be the adult pattern. Okay. Coming to Tanner stage 2 in males. So what was the first sign of puberty in males? The first sign of puberty in males was testicular enlargement. So in Tanner stage 2, puberty will start and it will come the first sign. So there will be what? There will be increase in testicular size. There will be increase in testicular size, and this testicular size becomes what? It becomes equal to 4 ml. It becomes equal to what? It becomes equal to 4 ml. Testicular volume or testicular size, the testicular size becomes equal to 4 ml. Alright. Along with that, what will happen after testicular enlargement was pubarc, right? So you will have sparse pubic hair in Tanner stage 2. You will have small pubic hair in Tanner stage 2. You will have sparse pubic hair. You will have sparse pubic hair. Then comes Tanner stage 3. So pubarc and then penile growth. Alright. So penile length will increase. Penile length is going to increase. Okay. Along with that, what will happen? The pubic hair, what is the third letter in the English alphabet? It is C. Pubic hair will start to undergo coarsening and curling. The pubic hair will start to curl and they start to become coarse. So there is going to be coarsening and curling of pubic hair. There is going to be coarsening and curling of pubic hair. This is Tanner stage 3. Testicular volume will become equal to 10 ml. It will become equal to 10 ml. In Tanner stage 4, the penile girth or the width will increase. The penile girth will increase. Alright, the penile girth will increase. Along with that, in Tanner stage 4, very importantly, in Tanner stage 4, males will have their growth spurt. Males will have their growth spurt. Males will have their growth spurt in Tanner stage 4. And finally, Tanner stage 5 is what? Tanner stage 5 is adult pattern. Alright, so Tanner stage 1 prepubertal, Tanner stage 5 adult pattern, Tanner stage 2 is what? The first sign of puberty. So testicular enlargement, increase in testicular size. After T comes P, pubarc, so sparse pubic hair. Tanner stage 3, third letter of English alphabet, C, coarsening and curling of pubic hair and increase in penile length. Tanner stage 4, growth spurt. Tanner stage 4, growth spurt and increase in penile width. So this is Tanner staging. So this is Tanner staging as far as your males are concerned. Moving on to Tanner staging as far as females are concerned. The same concept as far as males is valid. Tanner stage 1 will be prepubertal. Tanner stage 5 will be what? Tanner stage 5 will be adult pattern. Tanner stage 5 will be adult pattern. So Tanner stage 1 will be prepubertal. Tanner stage 1 will be prepubertal. And Tanner stage 5 is going to be what? It's going to be adult pattern. It's going to be adult pattern. Okay. Now, Tanner stage 2. So in Tanner stage 2, what is going to happen? What was the first sign of puberty in females? It was Pyloric, breast development. So in Tanner stage 2, breast development is going to occur. So what will happen? The breast bud is going to appear. Alright, the breast bud will appear. You will have a small breast growth. The breast bud will appear. And after T comes P. So again sparse pubic hair. Again what? Again sparse pubic hair. So breast bud is going to appear and sparse pubic hair as far as Tanner stage 2 is concerned. In Tanner stage 3, just like males, third letter of English alphabet, C. So coarsening and curling of pubic hair. So what? You will have coarsening and curling of pubic hair in Tanner stage 3. Okay. Along with this, very important, in females, the growth spurt occurs in Tanner stage 3. In males, the growth spurt used to occur in Tanner stage 4. In females, the growth spurt is going to occur in Tanner stage 3. So females will have what? They will have their growth spurt. Females will have their growth spurt. And this is something which you can remember from your own puberty days. Remember, back in the 5th, 6th, 7th standard, it was the girls, right? It was the girls who used to grow. So TANF stage 3. And then later in the 8th, 9th, 10th standard, that's when the boys, their height used to start to increase. Right? So the same thing is valid here also. TANF stage 3, the girls, the growth spurt is going to occur earlier, while in males, that is boys, the growth spurt is going to occur later in TANF stage 4. Girls, TANF stage 3, boys, TANF stage 4. Okay. Now coming to TANF stage 4 as far as girls are concerned. As far as TANF stage 4 is concerned, what is going to happen? The nipple and the areola. Till now, the breast growth was symmetrical. Now what will happen? The nipple and the areola, it will form a secondary mound. You know, a secondary kind of elevation, a mound formation over the rest of the breast tissue. So there is going to be formation of secondary mound. There is going to be formation of secondary mound by nipple and areola. The nipple and the areola over the rest of the breast tissue is going to form a secondary mound. So this is a defining feature. This is the defining feature of TANF stage. This is a defining feature of TANF stage 4. Apart from this, what is going to happen? You will have adult pattern pubic hair. So females have a inverted triangle shaped pubic hair. They will have that adult pattern pubic hair except medial thigh. Pubic hair won't be there on the medial aspect of the thigh. Rest pubic hair is going to be just like adult pattern. So adult type pubic hair except medial thigh. Except what? Except medial thigh. Pubic hair won't be there on the medial aspect of the thigh. Rest everywhere, pubic hair is going to be there. And finally, TANF stage 5. TANF stage 5 is, like I said, adult pattern. So now the pubic hair will be there, will be present on the medial aspect of thigh as well. It will be present on the medial aspect of the thigh as well. So everyone is answering all the questions correctly. I'm really happy that all of you know all these answers. Great. All right. So in TANF stage 5, what is going to happen? The pubic hair is going to be present on the medial aspect of thigh as well. Okay. TANF stage 4, just like adult pattern pubic hair, but not on medial thigh. TANF stage 5 going to be there on medial aspect, is going to be there on medial aspect of thigh as well. Or it's going to be there on medial aspect of thigh as well. All right. Now coming to milestones. Now coming to milestones. So let's revise the milestones. Let's revise the milestones. First, I'll revise what? First, we'll revise gross motor milestones. Now, as far as gross motor milestones are concerned, you can always remember the gross motor milestones by making a small stick figure. Okay. And in this stick figure, I always like to make this stick figure in helping in remembering the gross motor milestones. 3, 6, 9, 12. 3, 6, 9, 12. At 3 months, you will have neck control. At 3 months, what will happen? You will have neck control. At 3 months, you will have neck control. At 6 months, you will have a little bit of trunk control. Trunk control means the child will be able to sit with support. So at 6 months, child is able to what? Sit with support. At 6 months, child is able to sit with support. At 9 months, what will come? Knees will have control. So at 9 months, you will have knee control, means the child will be able to stand with support. So at 9 months, child is able to stand with support. Child is able to stand with support at 9 months. And at 12 months, finally, feet control will come. At 12 months, feet control. So now at 12 months, child will be able to walk with support. Child will be able to walk. Child will be able to walk with support. So 3, 6, 9 and 12. 3 months neck control, 6 months trunk control, 9 months knee control, that is standing with support. At 12 months feet control, means walking with support. If at 9 months, if at 9 months child is able to stand with support, he should be able to sit without support. The prior milestone fully should be developed, right? So at 8 months, child is able to sit without support. Child is able to sit without support. At 12 months, if the child is able to walk with support, you will only be able to walk with support if you are able to stand independently, if you are able to stand without support, right? So at 12 months, when the child is walking with support, child will also be able to do what? Child will be able to stand without support. Child will be able to stand child will be able to stand without support. Okay, so this is as far as your gross motor milestones 3, 6, 9 and 12 is concerned. Always remember 3 months neck control, 6 months trunk control, sit with support. Alright, 9 months is what? Knee control, so stand with support, and 12 months feet control, walk with support. If at 9 months child is able to stand with support, just prior child will be able to sit without support, and at 12 months if the child is able to walk with support, he should be able to stand without support. He should be able to stand without support. Apart from this, what you should remember is the difference is crawling and creeping. Crawling is when the baby is on all fours and the abdomen is touching the ground. Crawling has A in it, so A for abdomen, abdomen will be touching the ground. At 8 months, a child is able to crawl. A has abdomen in it, so abdomen will be touching the ground. And at 10 months, child is able to do what? Child is able to creep. Alright, when the child is creeping, what is happening? The abdomen will be above the ground. When a child is creeping, abdomen is above ground. Abdomen is above ground. Abdomen is above ground. Alright, now at 12 months, if the child is able to walk with support, 15 months, walk without support. Alright, how will you remember this? So I always like to recall a very famous dialogue from Ye Jawani Hai Diwani. So the Ranbir Kapoor character Bunny says what? मैं चलना चाहता हूँ, मैं दौड़ना चाहता हूँ, मैं उड़ना चाहता हूँ. He says this to Nana, right? So same thing the child will also do. At 15 months, child will, मैं चलना चाहता हूँ. Child will be able to walk without support. Child will be able to walk without support. मैं दौड़ना चाहता हूँ. 18 months, child is able to run. मैं उड़ना चाहता हूँ. At 2 years, obviously child won't fly, but at 2 years, child will be able to go up and down stairs. Okay? At 2 years, child is able to go up and down stairs. Child is able to go up and down. Child is able to go up and down stairs. But he's using both the feet. He's using both the feet when he's going up and down stairs. Okay? At 3 years of age, 3 has 3 in it. 3 has 3 in it. So tricycle. So tricycle. At 3 years, when the child is walking upstairs, he'll be able to use 1 feet. But when he's coming down, he will have a fear that he might fall. Alright, that's why he will still use 2 feet. So at 3 years, upstairs is 1 feet. Downstairs is 2 feet. Downstairs is 2 feet. This is at 3 years of age. At 4 years of age, child is able to go up and downstairs. Child is able to go up and downstairs 1 feet using only single feet. Okay, 1 feet. Apart from this, at 4 years, 4 has 4 in it. Hops also has 4 letters in it. So child is able to hop. 5 has 5 in it. Skips also has 5 letters in it. So child is able to skip. So child is able to skip. Just give me a moment. The battery will run out. Just give me 1 moment. 1 second. We'll start again. Alright, so this is as far as your gross motor milestones are concerned. 3, 6, 9, 12. Always remember this. 3, 6, 9, 12. 3 months, neck control. 6 months, trunk control means child is able to sit with support. 9 months, knee control. Stand with support. 12 months, feet control, walk with support. So at 12 months, walk with support. 15 months, मैं चलना चाहता हूँ, मैं दौड़ना चाहता हूँ, मैं उड़ना चाहता हूँ. At 15 months, child is able to walk without support. 18 months, child is able to run. And 2 years, उड़ना चाहता हूँ. Alright, not obviously fly, but both goes up and downstairs 2 feet at a time. 3 years, upstairs 1 feet, downstairs 2 feet. 3 has 3 in it. Tricycle also has 3 in it. 4 years, 4 letters. Hops has 4 letters. 5 years, 5 letters. Skips has 5 letters. Moving to the fine motor milestones. As far as fine motor milestones are concerned, at 3 months, what will happen? Child will bring both the hands into the midline and look at them very intently. At 3 months, child will bring both the hands into midline and look at them very intently. What's happening? At 3 months, child will brings hands into the midline, and he'll bring both the hands into the midline. He will look at them very intently. This intent looking of hands is also called hand regard. So hand regard will also come at 3 months. Hand regard will also come at 3 months. At 4 months, what will happen? If there is a dangling object in front of a baby, in front of the baby, he'll try to grasp it using both the hands. He'll try to catch it with both the hands. Alright, this is called bidextrous grasp or grip. But at 4 months, what will happen? Child will overshoot or undershoot. So at 4 months, you have bidextrous grasp. You have bidextrous grasp, but overshooting. But what? Overshoots. At 5 months, you will finally have proper bidextrous grasp with no overshooting. At 5 months, you will have bidextrous grasp, no overshooting. No overshooting. Okay. At 6 months, this bidextrous grasp will convert into unidextrous grasp. At 6 months, this will convert into unidextrous grasp. Alright, so if there is some object in front of the baby, he will be able to catch it with the help of a single hand. So hence, unidextrous. But at 6 months, when the child tries to hold an object, he'll try to hold it with the ulnar aspect of the hand. So he'll try to hold it like this. Normally, we hold it like this. He will try to hold it like this. This is called ulnar grasp. So at 6 months, this is ulnar grasp. At 6 months, this is what? This is ulnar grasp. At 7 months, this will turn into what? This will turn into radial grasp. At 7 months, this will turn into radial grasp. At 7 months, child will be able to hold it like this. But at 7 months, when he's holding an object, he's using the entire radial aspect of the hand. Okay? He's using the entire radial aspect of the hands. After 7 months comes what is called as pincer grasp. What is pincer grasp? That if you want to hold something, you are able to hold it with your index finger and your thumb finger. So this is what is called as pincer grasp, the way we are holding our pens. Alright. Now, if you're holding it using just your index finger and just your thumb, if you're holding it just like this is called mature pincer grasp. But let's say you hold it using your thumb, your index finger, and a little bit of support from your middle finger, like this. That will be immature pincer grasp. So at 9 months comes immature pincer grasp. At 12 months comes mature pincer grasp, when the child will be able to hold object like this, just the index and the thumb finger. That is mature pincer grasp. Mature pincer grasp is 1 year, and immature pincer grasp, when he's using a little bit of his middle finger, that is immature pincer grasp. That is at 9 months. That is at 9 months. So 9 months comes your immature pincer grasp. And at 12 months comes your mature pincer grasp. Now obviously at 12 months, let's say at 12 months child is holding a pencil. So at 15 months, what will the child do? At 15 months, child will start to do like this. At 12 months, he was holding a pen and a pencil. At 15 months, he'll start to do like this. This is what? This is scribbling. This is scribbling. So at 15 months, what will happen? Scribbling is going to start. At 15 months, scribbling is going to start. At 15 months, scribbling is going to start. Then we come to the drawing skills. Then we come to the important drawing skills as far as the baby is concerned. So at 2 years, 2 points. 2 years, 2 points. Child is able to draw a straight line between 2 points. Child is able to draw a straight line between 2 points. At 3 years, child is able to draw a circle. How will you remember this? A circle is present inside a 3. So 3 years, circle. 4 years, child is able to draw a cross. How will you remember? So cross also has a 4 in it. Cross also has a 4 in it. At 4.5 years, child is able to draw a rectangle or a square. child is able to draw a rectangle or a square. At 5 years, child is able to draw a triangle. Child is able to draw a triangle. At 7 years, diamond also has 7 letters in it. Diamond has 7 letters in it. So at 7 years, child is able to draw a diamond. Usually this is at 6 to 7 years. At 6 to 7 years, child is able to draw a diamond. Child is able to draw a diamond. Okay. So these are some important drawing skills. Alright. Coming to some important dressing skills. Now, if you are in a room with your significant other, let's say you're a female, you're in a room with your boyfriend, or let's say for all the boys in the house, let's say you are in a room with your girlfriend. Would the clothes come up or will the clothes go down? Would you be able to remove the clothes easily or will you be able to take the clothes easily? Obviously, you will be able to remove the clothes easily. So what I'm basically trying to say that it's always easier to take out the clothes as compared to take on the clothes. Okay. Same is valid for a child also. Child will be able to undress earlier as compared to dressing up. So child is able to undress with help at 2 years of age. But child is able to dress with help. Child is able to dress with help at 3 years of age. Child will be able to dress with help at 3 years of age. So if the child is able to dress with help at 3 years, he will be able to undress without help, right? So he will also be able to undress without help at the same time, that is 3 years of age. Now, child is able to button without any help at 4 years of age, and child is able to dress fully. Child is able to dress fully, requiring without any help whatsoever. This means including tying their own shoelaces. This occurs at 5 years. Coming to some important towers, putting blocks on top of each other to make towers. So child is able to make a tower of 2 cubes at 15 months. He is able to make a tower of 6 cubes at 2 years. And he is able to make a tower of 9 cubes. He is able to make a tower of 9 cubes at 3 years. How can you remember it? 2 into 3 is 6, 3 into 3 is 9. Right? 2 into 3 is 6 and 3 into 3 is 9. So that's how you can remember those two ones at least. Coming to some important social milestones. So social milestones. At 2 months of age, child has what is called as social smile. Child has social smile. At 3 months, when he was bringing the hands into midline, he was able to recognize his own hands. Obviously, if he's able to recognize his own hands, he will be able to recognize his own mother also. So at 3 months, recognition of mother comes. Recognizes mother. At 6 months, 6 has 6 in it. Mirror also has 6 letters in it. So mirror play. 7 has 7 in it. Anxiety also has 7 letters in it. Anxiety has 7 letters in it. So stranger anxiety will come at 7 months. 9 months. Bye. Again 9 letters. Bye. So child is able to wave bye at 9 months of age. Child waves bye at 9 months of age. At 12 months of age, that is 1 year, child will play a simple ball game and child can kiss on request. Alright, child plays a simple ball game and also kisses on request. At 15 months will come 2 P's. What are these 2 P's? First P is he'll point towards object. Second P is he'll point towards his own P. He'll wet himself and he'll point towards his own P. Alright, these are the 2 P's. So he will point towards object and point towards P. That is his own wet pants. At 18 months will come 2 D's. At 18 months, what will come? 2 D's will come. What are these 2 D's? First is domestic mimicry. First is domestic mimicry. The second D is dry at day. So child will he will have enough toilet skills, he will be dry at day. He'll be dry at day. At 2 years of age, 2 years means 2 parallel lines. 2 years, 2 parallel lines. Okay. So child will have what is called as parallel play. Child will have what is called as parallel play. What is parallel play? Basically, in a single room, if you have 2 children, both the children will pick up their own sets of toys but won't play with each other. So that is what's called as parallel play. They will be playing parallelly. So that's parallel play. This parallel play will turn into group play at 3 years of age. This parallel play will turn into cooperative play. It will turn into what? It will turn into cooperative play at 2 years. At 2 years, there is parallel play. At 3 years, there will be cooperative play. That they will start to play with each other. And at 4 years comes what? Group play. That multiple group of children will start to play with each other. At 4 years will come what? It will come group play will come. So 2 years, 2 children playing parallelly. 3 years, they will start to play with each other. That is cooperative play. And at 4 years will come group play. That they will start to play in group. Along with that, at 4 years, another thing comes which is called as role play. This is something which adults also do, right? So what is role play? Basically the ghar which a lot of children play, like or the police chore, the things they will play, that you become the thief, I'll become the police, like that. All right. So group play and role play, these are the things that will start at 4 years of age. Then coming to some important language milestones. Okay. At 2 months, vocalization will start. At 2 months, vocalization starts. At 3 months, 3 has 3 in it. Coo also has 3 letters in it. So cooing is going to start. 4 months, 4 has 4 in it. Ha ha. Ha ha also has 4 letters in it. So child will laugh out loud at 4 months of age. Ha ha also has 4 letters in it. At 6 months, what will start? Monosyllabic babbling. At 6 months, what will start? Monosyllabic babbling will start. Ma, ba, da. Ma, ba, da. This is monosyllabic babbling. This is what? This is monosyllabic babbling. This will start at 6 months. At 9 months, this will convert into bisyllabic babbling. Mama, baba, dada. Mama, baba, dada. So this is bisyllabic babbling. This will start at 9 months. At 1 year of age, child will be able to say 1 year. 1 year, one word. One word with meaning. 1 year, one word. One word with meaning. Child is able to say one word with meaning. At 15 months, what's going to happen? 15 has what? 5 in it. 15 has 5 in it. So vocabulary will be 5 words. 4 to 6 words vocabulary. 4 to 6 word vocabulary. And at 15 months starts what is called as jargon speech. Jargon speech will start. At 18 months has what? 8 in it. So 8 to 10 word vocabulary. 8 to 10 word vocabulary. And picture naming is going to start. Picture naming is going to start. At 2 years, 2-word sentences. Child says what? Child says 2-word sentences. Child is able to say 2-word sentences. What are these 2-word sentences? I go, मैं गया, he goes, he comes, you go. These are examples of 2-word sentences. All right. What are these 2-word sentences? These are your I go, he goes, like that. These are 2-word sentences. And what are these? What is this I and he? These are nothing but pronouns. These are nothing but pronouns. So these pronouns will also start to come at 2 years of age. So pronouns at 2 years. At 2 years, pronouns will also come. At 2 years, pronouns will also come. At 3 years, child is able to say 3-word sentences. Child is able to say 3-word sentences, and child also knows 3 things about himself. What are these 3 things? He knows his own name, age, and gender. He knows he's Aditya, he knows he's 3 years, he knows he's a male, like that. So 3 years, 3 things about himself. 3 things about himself. Name, age, gender. At 4 years, 4 has 4 in it. Poem also has 4 letters in it. Child is able to tell a poem. If he is able to tell a poem, obviously he will be able to tell a story also. So poem telling or storytelling starts. Similarly, another word has 4 letters in it. Past has 4 letters in it. So child is able to use past tense. Child is able to use past tense. After past will come future. So future tense will start at 5 years of age. So future tense will start at 5 years of age. At 5 years, child also asks meaning of word. Child also asks meaning of words. Child also asks meaning of words. All right. Apart from this, there are 2-3 milestones, simple milestones, which I want you to guys remember. That handedness, that whether you're a righty or a lefty, this handedness comes at 3 years of age. Then there's something called as right-left differentiation. That this is right side, this is left side. Obviously, this will come after handedness. So this right-left differentiation, this comes at 4 years of age. Okay. And there's something called as binocular vision. Something called as binocular vision. This binocular vision comes at 4 months of age. That you're able to use both the eyes and have a depth perception. That you're able to use both the eyes and have depth perception. This comes at 4 months of age. So these are some important milestones. Now we come to malnutrition. So first we'll understand the difference between acute and chronic malnutrition. Now, how do we judge acute malnutrition? How do we judge chronic malnutrition? Which is the best method, which is the best assessment method? See, let's say if I stop eating food for 1 month. All right, let's say we fast. Or if, let's for example, a child also starts to fast. He doesn't take food for 1 week or 2 weeks. Then what's going to happen? Will his weight decrease or will his height decrease? His weight will fall very rapidly, right? It's his weight which will fall very, very rapidly first. For height to decrease, time is taken. For someone to say that height is not normal, time is going to be taken. We discussed this in normal weight and length also. Weight was increasing very rapidly. Weight doubled in 5 months. Weight tripled in 1 year. Height doubling took 4 years. So this is a very important parameter between length and weight, that weight is something which occurs very quickly. Either the gaining of weight or the falling of weight. Both these things take very, very quickly. So as far as acute malnutrition is concerned, the better parameter will be a weight-based parameter. It will always be a weight-based parameter. The best method for acute malnutrition is, the best method to assess acute malnutrition is what? It is weight for length. It is what? It is weight for length. It is what? It is weight for length. As far as chronic malnutrition is concerned, something which occurs chronically. Now height will become a better parameter. Because for height to actually reduce, it is going to take a lot of time. It's going to take a lot of time that the height actually starts to reduce. Weight, very rapidly you can increase also. Weight, very rapidly you can decrease also. That's why for acute malnutrition, acuteness, weight is better, weight for length. For chronic malnutrition, height is going to be better. So the best method for chronic malnutrition is, it is your height for age. It is what? It is your height for age. It is your height for age. Okay. Now, if the weight for length is less than -2 standard deviation, if the weight for length is less than -2 standard deviation, see, between +2 and -2 standard deviation, between +2 and -2 standard deviation is what is normal. If the weight for length is less than -2 standard deviation, it will be moderate acute malnutrition. It will be moderate malnutrition, it will be moderate acute malnutrition. It's going to be what? It's going to be moderate. It's going to be moderate acute malnutrition. It's going to be what? It's going to be moderate acute malnutrition if it is less than -2. Let's say it's further down below, it's less than -3, even further fall in weight. Then it's going to be what? It's going to be severe acute malnutrition. It's going to be severe acute malnutrition, or SAM. It's going to be severe acute malnutrition, or SAM. Same thing is valid for height for age. Same thing is valid for height for age. Same thing is valid for height for age. If the height for age is less than -2, it will be moderate chronic malnutrition. It will be moderate chronic malnutrition. If the height for age, is less than -3, then it is also called as severe chronic malnutrition. Then it's called as severe chronic malnutrition. Then it's called as what? Severe chronic malnutrition. Alright. Now always remember that this acute malnutrition, whenever this weight for length falls below -2, whenever there is going to be acute malnutrition, this acute malnutrition, another term for acute malnutrition is wasting. Another term for acute malnutrition is wasting. So this moderate acute malnutrition can also be called moderate wasting. It can also be called moderate wasting. And severe acute malnutrition can also be called severe wasting. Severe acute malnutrition can also be called severe wasting. So anytime weight for length is less than -2, it is called wasting. If it is less than -2, moderate wasting, it's further less than -3, severe wasting. So another term for this acute malnutrition is wasting. Similarly, another term for this chronic malnutrition is what? It is stunting. It is stunting. So if the height for age is less than -2 standard deviation, we can call it either as moderate chronic malnutrition, or we can call it as moderate stunting. We can call it as moderate stunting. If the height for age is less than -3 standard deviation, we can call it as severe stunting. We can call it as what? We can call it as severe stunting. So another term for this chronic malnutrition is stunting. Another term for acute malnutrition is wasting. There is one parameter which I did not discuss. That is weight for age. Weight for age. Now, weight for age is one parameter which can be used for both acute and chronic malnutrition. Weight for age can actually be used for both acute and chronic malnutrition. Because it can be used for both acute and chronic malnutrition, it is being used for both acute and chronic. That's why it is not the best parameter for either of them. That's why it is not the best parameter for either of them. You need something which is very specific for that thing. So weight for length. Weight for length is very specific for acute malnutrition. Height for age is very specific for chronic malnutrition. Weight for age, your weight for age, it is there in both acute and chronic. So it doesn't have any specificity either for acute malnutrition or for chronic malnutrition. That's why it is not the best parameter for either of them. The best parameter for acute malnutrition, weight for length. Best parameter for chronic malnutrition, height for age. Weight for age can be used for both, but because it can be used for both, there is no specificity. Because there is no specificity, it is not the best parameter. Okay. If the weight for age is less than -2 standard deviation, it is called moderately underweight. The child will be called moderately underweight. Child will be called what? Moderately underweight. if the weight for age is less than -3 standard deviation, child will be called what? It will be called severely underweight. Child will be called severely underweight. So same, moderate and severe, but this time the term that is used, is underweight. This time the term that is used is what? It is underweight. Now the term is underweight. So if the weight for age is less than -2, moderately underweight. Weight for age is less than -3. Weight for age is less than -3, severely underweight. Okay? Child will be called what? Child is severely underweight. If the weight for age is less than -3, child will be severely underweight. Okay? Now, coming to some important differences between kwashiorkor and marasmus. Coming to the important differences between kwashiorkor and marasmus. Now, you have to understand that a lot of people say that kwashiorkor is protein loss, marasmus is calorie deficit. No, this is a wrong concept. Always remember that there is going to be protein loss in both kwashiorkor and marasmus. There's going to be what? There's going to be protein loss in both kwashiorkor and marasmus. The only difference is from where the protein is getting lost. In kwashiorkor, the baby loses protein. Which protein? Baby starts to lose visceral protein. What is visceral protein? Visceral protein is your albumin. Visceral protein is your neurotransmitters. Visceral protein is your enzymes. In kwashiorkor, there is visceral protein loss. While in marasmus, there is muscle protein, that is somatic protein loss. That is the main difference between kwashiorkor and marasmus. In kwashiorkor, there is visceral protein loss. What? In kwashiorkor, there is visceral protein loss. So you will lose your albumin, you will lose your enzymes, you will lose your neurotransmitters. If there are no neurotransmitters, child is going to be very lethargic. If there are no enzymes, obviously all the body functions will stop and child will die. So kwashiorkor is much more severe. In marasmus, there is what? There is somatic protein loss. Somatic protein means muscle is lost. Enzymes are not lost. Albumins are not lost. Neurotransmitter is not lost. If neurotransmitter is not lost, child will not be lethargic. Child will be irritable. Child will still want food. Enzymes are not lost. The prognosis will be better. The child won't die if you give him food. This is the core difference between kwashiorkor and marasmus. Kwashiorkor has visceral protein loss. That is, there is going to be loss of albumin, there is going to be loss of neurotransmitters, and child will be very lethargic. While in marasmus, there is muscle protein loss. There is what? Muscle protein loss. So in marasmus, child will be very irritable, but child won't die, or the prognosis is going to be better, because still the neurotransmitters are there, still the appetite of the child is there. So this is the main core difference between kwashiorkor and marasmus. Kwashiorkor is much more dangerous because you will lose the visceral protein, and visceral protein is much more important for survival. It is much more important for survival than your somatic or muscle protein. So that is the core difference. Always remember that. So how will a kwashiorkor child look? This is how a kwashiorkor child will look. Because you have lost albumin, what will happen? You will gain water. There will be edema. So there is going to be edema. So that's why the child will have ascites, edema, because of edema. And that edema and the ascites and the water gain will be there around the face also. So the face will become like a moon. Face will become circular because of the water gain. This is called as moon facies. This is called as moon facies. And people might falsely think that the baby is fat. That's why it's also called fat sugar appearance. It's also called fat sugar appearance. In marasmus, what will you see? You will see what? You will see loss of muscle mass. Like I said, somatic protein is lost. And if all the muscle and the fat from here is lost, child will become like this. This is what is called as simian or monkey face. This is called simian or monkey face. So that is the core difference between kwashiorkor and marasmus. Let's write them down. In kwashiorkor, there is wasting. There is wasting of what? There is visceral protein wasting. And there is going to be edema because of albumin loss. Marasmus, there is muscle wasting. That is your somatic protein wasting. Okay. Kwashiorkor typically tends to occur in children more than 1 year. Marasmus in less than 1 year. As far as appetite is concerned, kwashiorkor, no neurotransmitters, child is lethargic, so poor appetite. So a lethargic child and hence poor appetite. In marasmus, irritable child is irritable, then obviously appetite is normal or preserved. Appetite is preserved. In fact, they have a lot of appetite, a voracious appetite. Coming to appearance, in kwashiorkor, because they have gained a lot of water around their face, they will have moon faces or fat sugar baby appearance. Moon faces or fat sugar baby appearance. They will have what? They will have simian faces. They will have simian faces. Prognosis, kwashiorkor, obviously, like I said, visceral protein is more important for survival. So kwashiorkor will have poor prognosis, while marasmus will have better prognosis. Marasmus will have better prognosis. As far as deficit is concerned, so this is from the older times. If somebody asks an older question, in kwashiorkor there is protein deficit. In marasmus there is calorie deficit. There is calorie deficit. But like I told you, this is an incorrect concept. I'm only telling it to you because some old examiner might ask this question. But always remember that there is going to be protein loss in both. In kwashiorkor, it is the visceral protein which is lost. In marasmus, it is the somatic protein which is lost. As far as additional features are concerned, the additional features will be there in kwashiorkor because there are no enzymes. Enzymes are required for giving melanin. So there will be no melanin. So what will happen if there is no melanin? If there is no color, the hair will undergo this. There will be normal pigmentation, hypopigmentation, and again normal pigmentation. This is what is called as flag sign. So this flag sign will be seen where? It will be seen in kwashiorkor. Similarly, the skin will become like this. Again, normal pigmentation and dyspigmentation. And dyspigmentation or hypopigmentation. This is what is called as flaky pain dermatosis. This is what is called as flaky pain dermatosis. So these two things will be seen where? This will be seen in kwashiorkor. This flaky pain dermatosis and flag sign will be seen in kwashiorkor. Kwashiorkor also has a fatty liver. Kwashiorkor also has a fatty liver. Kwashiorkor also has a fatty liver. These things will not be there in marasmus. Flag sign, fatty liver, flaky pain dermatosis. 3 Fs. That's how you can remember. 3 Fs. What are the additional features? 3 Fs. Flaky pain dermatosis, flag sign, fatty liver. They will be there in kwashiorkor. They won't be there in marasmus. They will be there in kwashiorkor. They won't be there in marasmus. Now coming to severe acute malnutrition. Now how do you define severe acute malnutrition? So one definition we have already discussed, weight for length. We are using weight for length. If that weight for length was less than -2, it was moderate acute malnutrition. If the weight for length was less than -3, it was severe acute malnutrition. So if the weight for length is less than -3 standard deviation, is less than what? It's less than -3 standard deviation. Then you can say the child is having severe acute malnutrition. Or we use one thing called as mid-upper arm circumference. We'll take the arm circumference of the child. Okay, that will tell you whether the child is malnourished or not. If this mid-upper arm circumference, if this MUAC is less than 11.5 centimeter, if it is less than 11.5 centimeter, then you can say the child is malnourished. In fact, this MUAC is important. Let's discuss a little bit about this MUAC here itself. This mid-upper arm circumference is an age-independent parameter. You don't need to know the age of the child for this. It's an age-independent parameter. If it is less than 11.5 centimeter, child is said to be having what? Child is said to be having SAM. If it is between 11.5 to 12.5 centimeter, then that's borderline. If it's more than 12.5 centimeter, then that's normal. Then that's normal. And how do you measure this mid-upper arm circumference? Someone has already written that down. Shakir's tape. This mid-upper arm circumference is what? This is Shakir's tape. Measured with the help of what? Measured with the help of Shakir's tape. Right? This is how Shakir's tape looks like. It's something like this. It will have zones. It will have a lot of zones. It will have a red zone. Which is less than 11.5 centimeter. It will have a red zone. The Shakir tape will have a red zone which is less than 11.5 centimeter. Then it will have a small yellow zone. Then it will have a yellow zone, which is the borderline zone, the 11.5 to 12.5 centimeter zone. And beyond 12.5 centimeter, when you are normal, then that's a green zone. Okay, so this is as far as Shaki-Sem mid-upper arm circumference is concerned. Let's come back to SAM. How do you define SAM? If the weight for length is less than -3 standard deviation, you can call it as SAM. Or if the mid-upper arm circumference is less than 11.5 centimeter, you can again call it as SAM. Or if there is visible severe wasting, you can again call it as SAM. Or if there is bipedal nutritional edema. This bipedal nutritional edema was kept in the definition of SAM to ensure Kwashiorkor children are always called as SAM. To ensure that the Kwashiorkor children are always called as SAM. See, in Kwashiorkor, you know, is the most severe form of protein energy malnutrition. Obviously, that's going to be SAM. But in Kwashiorkor, what can happen? Because of the water gain, the weight for length can become normal. And if the water gain is here, the mid-upper arm circumference can be normal. So you would falsely classify that Kwashiorkor child as a normal child. You don't want that. That's why this bipedal nutritional edema. That's why this bipedal nutritional edema was kept. So that every child who has Kwashiorkor, that child will have edema, and you can classify that child as having SAM. You can classify a Kwashiorkor child as having SAM. So this is the definition of SAM. This definition is very, very important. Very, very important. Multiple times I have asked which of the following does not define SAM. Multiple times I have asked which of the following is not in the definition of SAM. And one of the options will be, let's say one of the option is height for age. One of the option is weight for age. That is not in the definition of SAM. See, in the definition of SAM, there is what? There is weight for length. There is mid-upper arm circumference, or there is edema. There is no weight for age. There is no height for age in the definition of SAM. Always remember that. Now, coming to the complications of SAM. See, the complications of SAM can be remembered by the mnemonic shielded. They can be remembered by the mnemonic shielded. Complications of SAM can be remembered by the mnemonic shielded. What is this shielded? S is sugar. So these children can have what? They can have hypoglycemia. The second H is hypothermia. The second H is hypothermia. They can have hypothermia. What is the definition of hypothermia? If the rectal temperature is less than 35.5 degrees Celsius, or if the axillary temperature is less than 35 degrees Celsius, that is the definition of hypothermia. I is infection. They can have a lot of infections. Which infections? Usually these are gram-negative organisms. And to treat these infections, do we do what? We give IV antibiotics. We give what? We give IV antibiotic. Which IV antibiotic? You will give ampicillin plus gentamicin. You will give ampicillin plus gentamicin. That is the IV antibiotic you will give. Okay. If this fails, let's say this fails, or let's say the child has meningitis. If say these antibiotic fails, ampicillin and gentamicin is not working, or let's say the child has meningitis. In that case, you will give what? You will give cefotaxime. You will give cefotaxime. Or any other third generation cephalosporin can also work, but usually we give cefotaxime. EL stands for electrolyte abnormalities. EL stands for electrolyte abnormalities. These children can have what? They can have hypernatremia. They can have hypernatremia, hypokalemia, and hypomagnesemia. These are the electrolyte abnormalities which are very common in children with SAM. Hypernatremia, sodium becomes high, potassium becomes low, magnesium becomes low. DE stands for dehydration. So obviously they can have a lot of dehydration. These children can have dehydration. And for their dehydration management, we don't use normal ORS. We use what? We use Risomol. We use what? We use Risomol. Rehydration solution for malnourished. We don't use normal ORS. We use Risomol. And the last D is deficiency, micronutrient deficiency. So they can have vitamin A deficiency, K deficiency, iron deficiency, all these things can be there. The one important thing that you have to remember that whenever we are giving this micronutrient supplement to them. We give a lot of micronutrient supplement to children with SAM, but don't give iron in first week. Just remember this very important point. that don't give iron in first week. Because if you give iron in first week, what will happen? The iron can generate a lot of free radicals. And in first week, initially, child will also have what? Child will also have infection. Infection will generate a lot of free radicals. Iron can also generate free radicals. And these free radicals can kill the child. That's why in the first week, we never give iron. Give iron after first week. Yes, you have to give iron, but give iron after first week. After first week. If you have to give iron after first week, not in the first week. Always remember. So these are the complications of SAM. You can have hypoglycemia, hypothermia, infection, electrolyte imbalance, dehydration, and micronutrient deficiency. All right. Now, since we are discussing micronutrient deficiency, let's discuss some important vitamin deficiency and what vitamin deficiency will cause. So vitamins we all know are of two types, fat soluble and water soluble. Water soluble vitamins are your vitamin B and C, vitamin B complex and C. Fat soluble is your vitamin A, D, E, and K. First, let's discuss water soluble vitamin deficiency. So vitamin B1 is what? Thiamine. Vitamin B1 deficiency causes what? It causes beriberi. It causes beriberi. Now, this beriberi, this thiamine is involved in what? This thiamine is actually involved in TCA cycle, citric acid cycle. So it's involved in energy generation. So whenever there is going to be what? Beriberi, the organs which require a lot of energy, they are the ones which are going to get affected first. Alright, so this thiamine is actually required for TCA cycles, that is energy generation. So whenever this thiamine is not there, energy generation won't be there. Energy requiring organs will be affected. Which energy requiring organs? Brain, nervous system, that's the first one. The other organ which requires energy is what? Heart. It's your heart. So the beriberi is of two types, wet beriberi and dry beriberi. In wet beriberi, heart is affected. In wet beriberi, what is affected? Heart is affected. Because heart is affected, there is going to be high output cardiac failure. And because there is heart failure will result in edema, water. That's why wet beriberi. In dry beriberi, there is going to be nervous system involvement, so there is going to be neuropathy. There is going to be neuropathy. You have beriberi if you take a diet which is rich in polished rice. Beriberi occurs if you take a diet rich in polished rice. The husk of rice contains a lot of vitamin B1. So if you polish the rice, then you will end up having beriberi. Then comes riboflavin. So riboflavin is a part of FADH2. And if you have riboflavin deficiency, you end up having this. Angular cheilitis, we all know angular cheilitis, ulcers will be there, angular cheilitis, and you can have corneal neovascularization. You can have what? Corneal neovascularization. So cornea, can you see here? Cornea will start to have new vessel generation, corneal neovascularization. Then comes niacin. Niacin is a part of your NAD, NADPH. It's a part of NAD and NADPH. And deficiency of niacin, we all know, results in what? It results in pellagra. It results in what? It results in pellagra. What are the 3 Ds of pellagra? This is something which all of you will know. Tell me, what are the 3 Ds of pellagra? Tell me, what are the 3 Ds of pellagra? Let's see. What are the 3 Ds of pellagra? Excellent, Dr. Phoenix. So it's going to be diarrhea, dementia, and dermatitis. It's going to be diarrhea, dementia, and dermatitis. All right. So this is how the dermatitis looks like. This is how the dermatitis looks like. Can you see? Can you feel that this child person was wearing a banyan? So typically the dermatitis is in those areas where he was not wearing a banyan. So typically this dermatitis is in sun exposed areas. Typically it is there in the sun exposed areas. Okay. And the dermatitis around this neck is called Castle's necklace. This dermatitis is also called as Castle's necklace. Now, niacin in our body can actually be formed from tryptophan. In our body, actually, tryptophan can also give rise to niacin. In our body, niacin can actually be formed from tryptophan. Okay, the pathway that forms tryptophan, that pathway that converts tryptophan into niacin, is called the kynurenine pathway. This kynurenine pathway requires vitamin B6. This kynurenine pathway requires vitamin B6. And this kynurenine pathway will be responsible for conversion of what? It will be responsible for conversion of tryptophan into niacin. So if there is, let's say, tryptophan deficiency, let's say there is tryptophan deficiency, niacin deficiency can occur. So niacin deficiency can occur in tryptophan deficiency. This is the reason why pellagra can also be seen in tryptophan deficiency apart from niacin deficiency. So pellagra can also be seen in tryptophan deficiency. It can also be seen in tryptophan deficiency. And where will you see this tryptophan deficiency? You can see this tryptophan deficiency in a disease called Hartnup disease. In Hartnup disease, what is happening? There is a absence of, it's an autosomal recessive, it's a genetic disorder where there is an absence of neutral amino acid transporter. Where there is an absence of neutral amino acid transporter. If this neutral amino acid transporter is not there, what will happen? You will not absorb tryptophan. You don't absorb tryptophan, no niacin, pellagra. Similarly, maize-rich diet. Very famous question. Maize-rich diet. If you take a lot of corn, maize doesn't contain any tryptophan. Maize lacks tryptophan. And it has high amounts of leucine. And this leucine is known to inhibit the kynurenine pathway. So a maize-rich diet, you're not taking enough tryptophan, again you'll end up having pellagra. Similarly, drugs like isoniazid, we all know isoniazid inhibits what? Isoniazid inhibits vitamin B6. So if vitamin B6 is not there, kynurenine pathway won't occur. If kynurenine pathway is not there, again you won't synthesize an adequate amount of niacin, you will again end up having pellagra. So this is as far as niacin deficiency is concerned. Now, pantothenic acid deficiency results in burning foot syndrome. It results in burning foot syndrome. Pyridoxine deficiency, what will it result in? So pyridoxine is involved in heme synthesis. So if there is pyridoxine deficiency, heme won't be able to synthesize. And when you're not able to synthesize heme, what is going to happen? All the iron will get deposited in the RBCs because it's not going to the heme. So this iron which gets deposited inside the RBCs, this kind of anemia is called sideroblastic anemia. So you will end up having what? You will end up having sideroblastic anemia in B6 deficiency. Then you will have raised ALT, AST. That can happen in B6 deficiency. And in adults, we all know in adults whenever we are giving isoniazid, isoniazid inhibits vitamin B6. And in adults, whenever you're giving isoniazids, we give vitamin B6 together to prevent what? To prevent peripheral neuropathy. Because vitamin B6 deficiency can cause peripheral neuropathy. So peripheral neuropathy is another important sign and symptom of vitamin B6 deficiency. And in neonates, it won't be neuropathy, it will be seizures. So neonates, vitamin B6 deficiency can result in refractory seizures. It can cause refractory seizures. Then comes biotin. Now, when will biotin deficiency occur? Biotin deficiency occurs when there is excess intake of raw white egg. If you take a lot of raw white egg, that can cause biotin deficiency. Biotin deficiency results in alopecia. Deficiency causes what? Alopecia, hair loss. Now we know both vitamin B9 and B12, they're involved in synthesis of blood. They're involved in DNA synthesis. They're involved in what? DNA synthesis. And if there is B9, B12 deficiency, both of it can result in megaloblastic anemia. This is something which you all know. It can result in megaloblastic anemia. B12 deficiency is different from vitamin B9 deficiency. That in B12 deficiency you have anemia along with CNS changes. So if there is only CNS changes, if there is only anemia, then it is B9 deficiency, that is folate deficiency. If you have both CNS changes along with anemia, then that is going to be vitamin B12 deficiency. Then comes vitamin C. Vitamin C is ascorbic acid. Main function of vitamin C in our body is hydroxylation of lysine and proline. It is hydroxylation of lysine and proline in collagen. That is the actual main function as far as vitamin C is concerned. Okay. So if there is going to be vitamin C, that is vitamin C deficiency, this collagen won't be formed. And if there is no collagen, if there is no collagen in gums, you will have gum bleed. You will have gum bleed. If there is no collagen in skin, you will have bleeding in skin, petechiae. That is petechiae. And you will also have bleeding in the joints. Joints also have a lot of collagen. You will have what? You will have bleeding in joints. You will have bleeding in joints. And you will have this. This is what is called as scorbutic rosary. This is what is called as scorbutic. Why is it occurring? Again, bleeding. If there is going to be, let's say, bleeding, if there is bleeding in the ribs, the blood will accumulate and form this bead-like structure. So that is your scorbutic rosary. And obviously, the scorbutic rosary is because it's occurring because of bleeding, is going to be very painful. It's going to be very painful. You can see the child is crying here. Okay, it's going to be very painful. Now we come to rickets. What is rickets? Rickets is nothing but defective. Rickets is nothing but defective mineralization. It is defective mineralization of bones. So all the clinical features, it is defective mineralization of bones. All the clinical features of rickets are because, why? Because the bones are not getting mineralized. So bones are lacking strength. That is the main problem in rickets. The first sign of rickets in children is craniotabes, which is also called ping pong skull. Ping pong skulls. So basically the bones, the skull bones, they are not mineralized. So one skull bone here, one skull bone here. When you palpate, it looks like it is table tennis ball because there is no mineralization in the middle. That's why it's called craniotabes or ping pong skull. Then obviously, if there is no mineralization of your teeth, you will have delayed dentition. You will have what? You will have delayed dentition. And you will also have delayed fontanel closure. Then there are some chest signs. What will happen if there is defective mineralization of your costochondral junction? You have costochondral junction here. That costochondral junction has cartilage. Ideally, it should get mineralized, get converted to bone. If it is not getting mineralized, then what's going to happen? If it's not getting mineralized, that cartilage will expand. There will be increase in the amount of that cartilage. And that cartilage, when it expands, again will result in more cartilage. It will again form balls. It will again form beads. This is what is called as rachitic. This is what is called as rachitic rosary. Why? Because of costochondral junction cartilage expansion. This occurs because there is costochondral junction cartilage expansion. The rachitic rosary occurs because of costochondral junction cartilage expansion. Another thing that will occur is Harrison sulcus. Harrison sulcus is nothing but a depression here. Why is that depression occurring? Because the ribs don't have strength. Ribs are not properly mineralized. When the child breathes, ribs are not able to maintain that structure of the rib cage. Alright? Ribs are not able to maintain the structure of the thoracic cage. They will go down. They will form a sulcus. They will form a depression. Again, why? Because of defective mineralization of the bones. Then in lower limbs, if you don't have proper mineralization, the lower limbs won't be able to take the weight of the upper limb. They will get bent. If they get bent in like this, if they get bent like this, like a bow, this is called as what? This is called bow legs. This is called bow legs. If they get bent like this, that the knees come together, they start to knock each other. That the knees come together like this is called knock knees. And if they bent like this, that one knee is this, then this is called wind swept deformity. That let's say wind is coming from this side and it swept the legs like this. This is called wind swept deformity. This is called wind swept deformity. Knock knees are also called genu valgum. Knock-knees are also called genu valgum. Gum joins things together. So knees are joining together. So genu valgum. And bow legs are also called genu varum. They're also called genu varum. So these will be the lower limb problems. Knock-knees or bow legs or a windswept deformity. An X-ray will look like this. Because there is no mineralization, the X-ray, what will happen? The metaphyses of the bone, they will become like this. They will become like cup. They will become like this. This is called cupping. Okay. The growth of the bone won't occur straight. It will go haywire. Again, because there is no proper mineralization. So instead of growing straight, it will start to go haywire. It will start to grow sideways. This is called splaying. So you'll see what? You will see cupping and splaying. But remember the first sign is not cupping and splaying. The first sign is actually lack of calcification. It is what? Lack of calcification. Again, because calcium is not getting deposited, mineralization is not occurring. It is, the first sign is lack of calcium, that is lack of calcification. That is the first sign. Lack of provisional zone of calcification, actually, if I go in a little bit further, that is the first sign. That is the first sign. Other things will be cupping and splaying. Another thing is fraying. Fraying also occurs. What is fraying? That this bone, this frizzled, frizzled appearance, that is called fraying. That's called fraying. So cupping, splaying and fraying will be seen. So these are the three things that you see in X-ray. Then we come to vitamin A. The main function of vitamin A is epithelial differentiation and integrity. It is epithelial differentiation and integrity and vision. Okay, what will happen to the eyes? We all know vitamin A is required for your normal, maintaining normal vision. So whenever there is vitamin A deficiency, the eyes are the ones which are going to get affected. So the WHO has given classification of this vitamin A deficiency, X1A. If there is in X1A, what's going to happen? There's going to be conjunctival cirrhosis. The conjunctiva epithelium, it will lose water because epithelial differentiation and integrity is not there. So the conjunctival epithelium will lose water. It will become dry. This is what is called as conjunctival cirrhosis. That is X1A. This is the first sign of vitamin A deficiency. If they ask you the first symptom, then that will be night blindness. Remember, the first symptom is actually night blindness. It is night blindness. The first sign, the conjunctiva will become dry because the epithelium is lacking integrity. There is no epithelial integrity. Epithelium will lose water. So conjunctival epithelium will become very, very dry. So conjunctival cirrhosis. X1B, the epithelium becomes very dry. Epithelium will form a lot of concretions like this. Alright, the epithelium will form a lot of concretions. This is what is called as Bitot spots. That is X1B. X2, now the cornea becomes dry. Corneal cirrhosis. And one thing, when it becomes dry, after drying, so whenever we have dry lips, what happens after a point of time? The dry lips, they become cracked. The same thing will happen with cornea also. After corneal cirrhosis, the cornea will crack. There will be corneal ulceration. So X3 is what? Ulcer formation. Corneal ulcer. X3 is when the ulcer is less than 1/3 the total surface area. B is when it is more than 1/3 the total surface area. So that is corneal ulceration. Treatment. You give vitamin A. The dose will be dependent upon the age of the child. Less than 6 months, 50,000. 6 to 12 months, 1 lakh. More than 12 months, 2 lakh. This will be the dose of vitamin A. And you will give this vitamin A on day 0, day 1 and day 14. So on the day the child comes, you will give vitamin A, day 1. The next day you will give vitamin A and 2 weeks later you will give vitamin A. The dose will be dependent upon the age of the child. Last is your vitamin K. Now vitamin K is required for gamma carboxylation. It is required for gamma carboxylation of factors 2, 7, 9 and 10. 2, 7, 9, 10. Coagulation factors. So if there is no vitamin K, if there is vitamin K deficiency, what's going to happen? The gamma carboxylation won't occur. So these factors, they won't be able to act. And if there is deficiency of coagulation factors, what will occur? Bleeding will occur. Particularly, it will occur in newborns. So vitamin K deficiency particularly causes hemorrhagic disease of newborn. Why newborn? Why particularly newborn? Because newborns take what? They take breast milk. And breast milk has inadequate amount of vitamin K. So this brings me to the next topic, that is breastfeeding and breast milk. Remember that breast milk has inadequate amount of vitamin K. It has inadequate amount of another vitamin, that is your vitamin D. These are the only two vitamins which are lacking as far as breast milk is concerned. As far as breast milk is concerned, two vitamins which are lacking. Since vitamin K is lacking, we usually give if vitamin K is lacking, what do? We give injection vitamin K. We do what? We give injection vitamin K at birth. This is the reason why we give injection vitamin K at birth. And for vitamin D, what do? We give vitamin D drops. We give what? We give vitamin D drops for 1 year. For 1 year. Because breast milk is lacking vitamin K, we give injection vitamin K at birth. Because vitamin D is lacking, we give vitamin D drops for 1 year. Now coming to some important differences between breast milk and cow milk. Now as far as breast milk is concerned, the amount of protein is lesser in breast milk as compared to cow milk. It is around 1 gram per deciliter. Cow's milk has 4 gram per deciliter. It has 4 gram per deciliter. But even though the breast milk has lower amount of protein, this protein is more absorbable. The waste to casein ratio in this breast milk is actually 60:40. It is 60:40. While in cow's milk, this ratio is 20:80. That is, casein is more. Casein is more. C for casein, C for cow's milk. This casein is more in cow's milk. And casein is known to what? It is known to coagulate. It is known to coagulate. So this casein, it will coagulate, it won't be absorbed. It will not be absorbed. So in cow's milk, you have more casein which coagulates and is not absorbed. In normal human breast milk, you have more what? You have more whey. And this whey is more easily absorbable. It is more easily absorbable. As far as fat is concerned, between breast and cow's milk, the amount of fat is equal. Around 3 to 4 gram per deciliter. It is also same, 3 to 4 gram per deciliter. But the human breast milk has 30 times more DHA which is required for brain growth. It has 30x more DHA which is required for brain growth. So even in this category, the breast milk is better. As far as lactose is concerned, lactose is more in breast milk. It is 7 gram per deciliter, while it is only 4 gram per deciliter in cow's milk. And more lactose means more energy. As far as calcium phosphate is concerned, in breast milk, this calcium phosphate is in a 2:1 ratio. While in cow's milk, it is in a 1.5:1 ratio. This 2:1 ratio helps in absorption of calcium. Helps in absorption of calcium. Because if there is more phosphate, which is the case as far as cow's milk is concerned, more phosphate will do what? Phosphate will chelate with calcium. It won't allow the calcium to get absorbed. That's why in the breast milk, the calcium is more easily absorbable. That's why the calcium is more easily absorbable in breast milk as compared to cow's milk. So these are some important differences. These are some important differences as far as cow's milk and breast milk is concerned. Coming to the different types of milk feeding pattern wise. First is your foremilk, next is your hindmilk. Foremilk has more water. So it helps in quenching the thirst of the baby. Foremilk is the milk which comes first. So it helps in what? It quenches the thirst of the baby. Hindmilk has more fat. So it does what? It quenches the hunger of the baby or satiety of the baby. Then the milk which comes in the first 2 weeks, is called colostrum. This colostrum is rich what? It is rich in IgA. IgA is what? It's a type of protein. So it's rich in proteins. And the color of this colostrum is what? It is yellow. It is yellow in color. It is yellow in color. As the milk progresses, what keeps on happening? The protein content keeps on decreasing. And finally, you will have mature milk, which will be less in protein, more in fats. Okay, the mature protein is rich in fats. Okay, so initially you have a colostrum which is rich in proteins, which is rich in IgA. This protects the baby against. It is a type of passive immunity. It's a type of what? Passive immunity that's given to the baby. Okay, while mature milk will have more fats. It will have more fats. So this is as far as the milk pattern is concerned. Now, signs of good attachment. Again, something which is asked very frequently. Signs of good attachment. So this is how a baby should look like when it is taking the breastfeeding. The chin of the baby should touch the breast. So that's the first thing. Chin should touch the breast. It should touch the breast. Mouth. Can you see the mouth? Wide open. Mouth should be wide open. Mouth should be what? It should be wide open. The third thing, the lower lip. The lower lip should be everted. Okay? Lower lip should be everted. And most of the areola, if not all, most of the areola should be inside the mother's, it should be inside the baby's mouth. Most of the areola should be inside baby's mouth. Only the upper part of areola, a little bit of upper part of areola can be visible, but rest of the areola should be inside the baby's mouth. So these are the 4 signs of good attachment. Very important, very important. These are the 4 signs of good attachment. All right. These are the 4 signs of good attachment. Now coming to some important scores in neonatology. In neonatology, I'll discuss some important scores. Okay. First is your APGAR score. Very important, very frequently asked APGAR score. What are the 5 components of APGAR score? You can remember by the mnemonic APGAR itself. By the mnemonic APGAR itself. All right. By the mnemonic APGAR itself. APGAR is appearance, pulse. What are these 5 components? Appearance, pulse, grimace, activity, and respiration. These are the 5 components of the APGAR score. As far as APGAR appearance is concerned, you'll give a score of 0 if the child is fully cyanosed. You'll give a score of 1 if there is acrocyanosis, that the body is pink but the limbs are cyanosed. 1 is if there is acrocyanosis. 2 is if the body is fully pink. The body is fully pink. Pulse. No pulse. No pulse, 0. If the heart rate of the pulse is less than 100, 1. More than 100, 2. Grimace. Grimace is what? We put a nasal catheter and we see if the child does like this. That is called grimace. So if there is no grimace, 0. Some grimace, 1. Full grimace. Or if the child, let's say, sneezes. You're putting a nasal catheter, child can sneeze. So the child sneezes. If there is full grimace, or let's say the child sneezes, baby sneezes, then give a score of 2. Activity. Alright. If there is no activity, child is fully limp, score of 0. If there is partial flexion, 1. Or there is some activity. Okay. 2. If the child is fully flexed, fully active, there is full flexion and full activity, then a score of 2. As far as respiration is concerned, if the child is apneic, that is no respiration, 0. Score of 1 if there is respiration with difficulty. A little bit of difficulty is there, then you will give score of 1. And if the child is normally crying, then we give a score of 2. So that's as far as APGAR score is concerned. Coming to another important score, that is a Silverman-Anderson score. Coming to here, another important score, that is Silverman-Anderson score. Another score, Silverman-Anderson. What are the 5 components of Silverman-Anderson score? The 5 components here are upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring, and grunting. These are the 5 components of Silverman-Anderson score. Okay, these are the 5 components of Silverman-Anderson score. Now, as far as Silverman-Anderson score is concerned, you will give a score of 0 for upper chest retractions if there are no retractions, none. You will give a score of 1. Look at here. Let's assume this is how this is the upper chest, this is the lower chest, this is the abdomen. Imagine this is the upper chest and this is the abdomen. Okay. If there is some pathology, what will happen? Normally when we are breathing, the abdomen also moves up, the chest also moves up. Normally this is together. If there is some pathology in the chest, what will happen? The abdomen will move up, but chest will not move. Chest will lag behind. The abdomen. This is given a score of 1. If there is a lag, you will give a score of 1. Now imagine a scenario where the abdomen has fully moved up. Chest hasn't moved at all. Abdomen comes down, now the chest moves up. Chest moves down, abdomen comes up. Like this. This is called seesaw movements. Then you will give a score of 2. In seesaw movements, you will give a score of 2. Okay. As far as lower chest retractions are concerned, concerned, you will give a score of 0 if there are no lower chest retractions, score of 1 if there are minimal or mild lower chest retractions, and if there are marked lower chest retractions, you will give a score of 2, marked or severe. Same for xiphoid retractions, no xiphoid retractions, score of 0, minimal xiphoid retractions, score of 1, marked xiphoid retractions, score of 2. Same for nasal flaring as well. No nasal flaring, score of 0, minimal nasal flaring, a little bit of nasal flaring, score of 1, marked nasal flaring, score of 2. Grunting. Again, no grunting, 0. If this grunting is audible with stethoscope, score of 1. If you can hear it without hearing stethoscope, with ears also, if you can hear it with ears also, then score of 2. So this is as far as Silverman-Anderson score is concerned. Coming to respiratory distress, some important respiratory distress disorders. 2 disorders I'll cover today. Only 2 disorders I'll cover today. I can't cover everything in detail today, obviously, because it's a one shot. But 2 most important which have been asked very frequently. One is your respiratory distress syndrome. Other is your this is your, we all know this is congenital diaphragmatic hernia. So let's discuss respiratory distress syndrome. Why does respiratory distress syndrome occur? It occurs because a child is born preterm. Usually will occur if the child is born at less than 34-week period of gestation. Okay, and because the child is born preterm, what is going to happen? There will be lack of surfactant. There's going to be what? There's going to be lack of surfactant. And if there is lack of surfactant, what is going to happen? There will be increased surface tension. There will be increased surface tension, and this increased surface tension will cause what? It will cause alveolar collapse. It will cause alveolar collapse. So this is as far as your respiratory distress syndrome is concerned. For this respiratory distress syndrome, we do what? We do a ratio called LS ratio. This L is lecithin and S is sphingomyelin. Lecithin is the main component of surfactant. So in RDS, lecithin will be lower. So this LOS ratio is less than 2 in RDS. It is less than 2 in RDS. Then we do another test called shake test. We do another test called shake test. What do we shake? We take a test tube. In this test tube, we take some alcohol and we put the gastric aspirate of the baby. We take the gastric aspirate of the baby and then we do what? We shake it. And then we do what? We shake it. We'll take alcohol, we'll take gastric aspirate and then we'll shake it. If there is adequate surfactant, what will happen? That surfactant will cause what? That surfactant will cause bubbling. If there is inadequate surfactant, you won't see any bubble. So this is what is called as shake test. If there is adequate surfactant, what will happen? You will see bubbles when you do that shake. You will see bubbles. Bubbles will be there. If there is inadequate surfactant, there won't be any bubbles. Bubbles won't be there. You won't see any bubbling. You won't see any bubbling. Now, what will the X-ray look like? This is how the X-ray looks like. You'll see a complete whiteout, but you will see what? The big bronchioles and the big trachea, they will still have air. The peripheral alveoli will be fully collapsed, so whiteout, but in the middle you can see. If you here also, if you look closely, you can see the air being present. You can see the air being present in the big bronchus. This is called air bronchograms. So you see what? You will see air bronchograms. You will see what? You will see air bronchograms plus, you will see air bronchograms plus you will see a whiteout. A whiteout in periphery. Periphery will be white, fully collapsed, but in the middle you will see some air. In the middle you will see some air. Alright, if you look closely, here, small hair, a little hair here, a little bit of air here, you can see. This is called air bronchograms. For prevention, will you do what? For prevention, we'll use antenatal steroids. You can either use betamethasone or dexamethasone. You can either use betamethasone or you can use dexamethasone. Betamethasone, B for beta, B for bara. B for beta, B for bara. So the dose is 12 mg given 2 times 24 hours apart. The dose is 12 mg given 2 times 24 hours apart. In dexamethasone, you give a dose of 6 mg 4 times 12 hours apart. Okay. So beta, B for beta, B for bara. 12 mg 2 times. Dexa has dexamethasone 6 mg 4 times. Okay. Now this very frequently tested. This is what? This is congenital diaphragmatic hernia, CDH, congenital. This is what? This is CDH, congenital diaphragmatic hernia. So the diaphragm is not there. If the diaphragm is not there, all the intestine will come into the thorax. All the intestine. Can you see the intestine? This is nothing but your intestine. This is nothing but your intestine. The intestine will come where? It will come into the thorax. The most common site is what? It is left posterolateral. Most common site of this CDH is what? Left posterolateral. Most common type is Bogdelic type. Alright. The most common question that they ask is that bag and mask is contraindicated. Why? See, when you do bag and mask ventilation, what is going to happen? The air will go into these intestine, into the stomach and intestine. So these intestine will further. They will what? They will further enlarge. If they further enlarge, they will further compress the already compressed lung. That is the reason why bag and mask ventilation is contraindicated. What is the cause of death? So these intestine, when they come into the thoracic cavity, they won't allow the lungs to grow. And the lungs will be hypoplastic. There will be lung hypoplasia. And this lung hypoplasia is the cause of death. So the main cause of death is what? The main cause of death is lung hypoplasia. main cause of death is lung hypoplasia. It is your lung hypoplasia. All right. So this is as far as your CDH is concerned. So this is a little bit of neonatology. I'm so sorry I won't discuss NRP today, neonatal resuscitation. It's a little bit too lengthy as far as NRP is concerned. So that's why I'm not going to be discussing today in a one shot. But you can always watch the prior videos of mine where or the main videos of mine on the app where you can discuss NRP in a little more detail. I'm so sorry I won't discuss NRP today. Now, the next thing that I'm going to discuss is the differences between some two important syndromes. Two important syndromes, Edward and Patau. Edward and Patau syndrome. All right, I'll discuss Edward and Patau syndrome. Now, as far as the Edward and Patau syndrome is concerned, a lot of you can get confused between the features of Edward and Patau syndrome. The simplest way you can remember the symptoms and the signs of Edward and Patau is P. If you hear the sound of P in it, it's going to be there in Patau. If you don't hear P, it's going to be there in Edward. Always remember P for Patau, rest everything Edward. P for Patau. Always remember that. That's it. That's the only thing that you need to remember. Now, in Edward syndrome, there's going to be what? There's going to be E for Edward, E for 18. Trisomy 18. P for Patau, P for puberty. Puberty, when does puberty start? At 13 years of age. So, it's going to be trisomy 13. Cleft palate. You're hearing the sound of P. So, cleft palate is going to be there in Patau, not going to be there in Edwards. As far as hands are concerned, P for Patau, P for polydactyly. So, polydactyly in Patau. As far as Edward is concerned, you will see what? You will see overlapping fingers. You will see overlapping fingers. You will see overlapping fingers. As far as kidneys are concerned, horseshoe kidney. Horseshoe kidney. Any P in it? No. So horseshoe kidney is seen in Edward. Horseshoe kidney is seen in Edward. As far as Patau is concerned, P for Patau, P for polycystic kidney. Alright, so polydactyly, polycystic kidney, Patau syndrome. Rocker bottom feet, no P. Rocker bottom feet, no P. So rocker bottom feet is seen in Edward. Rocker bottom feet is seen in Edward, not in Patau. Not in Patau. And last is holoprosencephaly, P. Again you are hearing a sound of P. So holoprosencephaly is seen where? In Patau, not seen in Edward. So this is how you can easily differentiate between Edward and Patau syndrome. You hear the sound of P, Patau. You don't hear the sound of P, Edward. Plain and simple. Okay? Plain and simple. So this, can you see the cleft palate? So this is going to be what? This is going to be Patau. Here, can you see the overlapping fingers? These are overlapping fingers. Fingers are overlapping each other. So this is going to be what? This is going to be Edward. It's going to be Edward. And this is what? Rocker bottom feet, like a rocking chair. Like a normal rocking chair. It's a rocker bottom feet. So again, this is going to be what? This is going to be there in Edward. It's going to be there in Edward syndrome. It's going to be there in Edward syndrome. It's going to be there in Edward syndrome. Then we come to this. If you look at this girl, can you see this? Can you see the widely spaced nipple? Can you see this? Can you see there's a web? Like there's a web of, this is called web neck. This is called web neck. Now, this web neck, this widely spaced nipple, another thing is there is wide carrying angle. These things can be there in both Nunan and Turner. Both of them have the same phenotype. Alright? Both Nunan and Turner have same phenotype. That is same physical appearance. So physically they will appear, both of them will appear same. Both of them will appear same. That is, they will have this, what I call as 3 Ws. Both of them can have widely spaced nipple. Both of them can have webbed neck, and both of them can have what? Both of them can have wide carrying angle. So the physical appearance, the widely spaced nipple, the webbed neck, the wide carrying angle can be there in both Nunan and Turner syndrome. Both of them can have also short stature. Both of them can have short stature as well. Then how do you differentiate between Nunan and Turner? And what is the core difference between Nunan and Turner? The core difference lies in the cause, that is the genetic cause. The core difference lies in the genetic cause. Turner, we all know is what? Turner is XO, that is monosomy X. Turner is what? Monosomy X. Well, Nunan is actually a autosomal dominant disorder. Nunan is actually a autosomal dominant disorder because of PTPN. Because of PTPN mutation. Because of PTPN mutation. Because of PTPN mutation. Okay. Nunan is what? It is autosomal dominant disorder because of PTPN11 mutation. While Turner is a monosomy X. As far as other differences concerned, Nunan, the most common heart problem is pulmonary stenosis. It is what? Pulmonary stenosis. That is the right side of the heart is involved in Nunan. While as far as Turner syndrome is concerned, in Turner syndrome, left side of the heart, the aortic side is involved more. You have what? You have bicuspid aortic wall. You have what? Bicuspid aortic wall. That is the most common heart problem. That is the most common heart problem. Alright. As far as IQ is concerned, in Turner the IQ is normal. The IQ is normal while it is decreased in Nunan. And Turner, monosomy X. So Turner has streak gonads. It's a sex aneuploidy. All sex aneuploidy will have problems with fertility. So Turner is infertile. There are what? Streak gonads. While Nunan, the fertility is preserved. Fertility is preserved. But there are subfertile. Less fertile than normal. In fact, males can have what? Males can have cryptorchidism. Males can have cryptorchidism. So less fertility but not infertile. While Turner will always be what? Turner will always be infertile. Turner will always be infertile. In the end, yes, Phoenix, I will towards the end, I will also talk about some topics which probably won't be covered today. I will definitely talk about the topics which are definitely not covered today. I'll talk about that as well. Now I'll come to systemic pediatrics. I'll come to diarrhea, the management of diarrhea. I'll come to the management of diarrhea. Very important. Dehydration management, diarrhea management. Very, very important. Diarrheal management, very important. Now there was a question, very common question which is asked, which is the most common cause of diarrhea in children? Remember, the most common cause of diarrhea in children is what? It is rotavirus. It is rotavirus. What causes rice watery stools, rice watery diarrhea? Cholera, Vibrio cholera. And most common bacterial cause is E. coli. It is what? E. coli. Simple one-liners which can be asked. Most common cause of diarrhea in children is always a virus. It's a viral disease, rotavirus. Rice watery stools, cholera, Vibrio cholera. Most common bacterial cause, E. coli. Now, management of diarrhea, as far as management of diarrhea is concerned, it is not the diarrhea which kills. It is actually the dehydration that occurs because of diarrhea which kills. So, the management of diarrhea focuses on management of dehydration. Along with that, we give zinc to every child who has diarrhea. Because zinc helps in epithelial integrity and preservation. So, zinc decreases the duration of diarrhea. So, zinc, if the child is less than 6 months, we give 10 mg for 14 days. The child is more than 6 months, we give 20 mg for 14 days. Alright. A child who has come to us with diarrhea and dehydration, first what we have to do, we have to classify this dehydration into 3 main categories. Okay, 3 main categories. What are the 3 main categories? These are your no dehydration, some dehydration, and severe dehydration. No, some, and severe. So when a child with diarrhea comes to us, we'll classify this dehydration. We'll classify this dehydration into no dehydration, some dehydration, and severe dehydration. Now, how do you differentiate between this no dehydration, some dehydration, and severe dehydration? We're going to use 4 parameters. We're going to use what? 4 parameters. Consciousness, thirst, skin pinch, and eyes. These are 4 parameters we'll use to differentiate between no dehydration, some dehydration, and severe dehydration. In no dehydration, consciousness will be normal, child will be active, alert. Alright. In some dehydration, what will start to happen? Because now the baby has lost a lot of water, child will start to become a little bit irritable. Okay, so child will be what? Irritable. In severe dehydration, what will happen? Now body has lost a lot of water, severely dehydrated. So child will become very lethargic or comatose. Child will become lethargic or comatose. As far as thirst is concerned, thirst again normal in no dehydration. In some dehydration, child will be very thirsty. He's irritable because he's not getting water. He's irritable because he's not getting water. So if you give him water, he'll take a lot of water. So drinks water eagerly or very thirsty. So in some dehydration, drinks eagerly or very thirsty. Or very thirsty. While in severe dehydration, child is what? In severe dehydration, child is lethargic. Do you think he'll be able to drink water? He won't be able to drink water. So, unable to drink. Unable to drink. Skin pinch. No dehydration, normal skin pinch. Some dehydration, a little bit delayed. Goes back slowly. In severe dehydration, goes back very slowly. Goes back very slowly. Okay, eyes will be normal in no dehydration. In some dehydration, they will be sunken. In severe dehydration, they will be very sunken. They will be what? Very sunken. They'll be very sunken. Okay. If you have any 2 out of these 4, you will classify into that category. So let's say someone has lethargy, comatose, someone is unable to drink. Even if the other 2 parameters are not met, you will classify into severe dehydration. Any 2 out of the 4, you will classify into that category. Now, coming to the management. So there are 3 plans that we use. Alright, we'll use plan A for no dehydration, we'll use plan B for some dehydration, and we'll use plan C for severe dehydration. Plan A, plan B, plan C. Plan A is for no dehydration. It's for no dehydration. If there is no dehydration, you don't need to rehydrate. So in plan A, what do? You just replace ongoing fluid losses. You'll just replace ongoing fluid losses. And every time a child has a loose stool, replace that. How much? You'll give 10 ml per kg of ORS with each loose stool. Okay. Every time child has a loose stool, give him 10 ml per kg of ORS. That's it. That's the only thing that you need to do in no dehydration. That you will just replace the ongoing fluid losses, you will replace the ongoing diarrhea losses. Anytime child has a loose stool, give him 10 ml per kg of ORS. That's it. So as far as this ORS is concerned, how is this ORS made? A little bit about that. So normally this ORS has 75 millimole per liter of glucose, sodium, 75 of glucose as well, 20 of potassium, 65 of chloride, and 10 of citrate. So that the total is what? Total is 245. Total is 245. Alright. I told you when we were discussing SAM that in SAM we use what? Resomol, rehydration solution for malnourished. How is that Resomol different? How is that resomol different? In that resomol, sodium is what? Sodium is 75, sodium is 45. Sodium is 45. Why? Remember in SAM I told you there's going to be hypernatremia. So in resomol, the sodium is kept lower, 45. In SAM you can have hypoglycemia. So glucose is kept higher, 125. Hypokalemia, potassium also kept higher, 40. Chloride is 75. Citrate is 7. Along with that, they will have 3 amount. It will have 3 of magnesium. Remember we said there's going to be hypomagnesemia. So that's how resomol is different. That's how resomol is different. Glucose is higher because hypoglycemia risk. Sodium is lower because there was hypernatremia. There is magnesium because there was hypomagnesemia. There was hypomagnesemia. And potassium is also higher, 14 resomol, 20 in ORS. Why? Because hypokalemia was there in SAM. So that's how resomol is different from normal ORS. Okay. Coming to plan B. In plan B is used for what? Some dehydration. Now child is some dehydrated. So now you will replace that amount of diarrhea losses that has occurred. So you'll do what? You'll give ORS. He's taking orally because he was very thirsty. So you'll give orally only. You'll give orally only or NG. No role of IV fluids in plan B. In some dehydration, child can take orally, give orally only. How much? You will give 75 ml per kg of ORS. You will give 75 ml per kg of ORS over 4 hours. You will give 75 ml per kg of ORS over 4 hours. That is some dehydration. That is in some dehydration. So you will replace whatever he has lost, 75 ml per kg over 4 hours. Coming to plan C. Plan C is for severe dehydration. Plan C is for severe dehydration. Now in severe dehydration, child was lethargic, comatose. You cannot give orally now. You have to give IV. You have to give IV. You have to give IV fluids. You have to give what? You have to give IV fluids. Which IV fluid? You will give RL with 5% dextrose, preferred over RL, preferred over NS. The preferred IV fluid is what? It is RL with 5% dextrose. It is RL with 5% dextrose. How much? 100 ml per kg now. Now you have to give how much? 100 ml per kg. This 100 ml per kg is given in 2 aliquots, 30 ml per kg and 70 ml per kg. 30 ml per kg and 70 ml per kg. If the child is less than 1 year old, this 30 ml per kg is given over 1 hour. The remaining 70 ml per kg is given over 5 hours. So that the total 100 ml per kg is given over 6 hours. If the child is more than 1 year old, then this 30 ml per kg is given over half hour. The remaining 70 ml per kg is given over 2.5 hours. So that the entire 100 ml per kg is given over 3 hours. This is as far as severe dehydration is concerned. Severe dehydration, child is lethargic. You have to give IV fluids. Which IV fluids? RL with 5% dextrose, 100 ml per kg. Okay. First 30 ml per kg over 1 hour and the remaining 70 ml per kg over 5 hours. So the total 100 ml per kg is given over 6 hours in children less than 1 year. In more than 1 year, you will give it over half the time. 30 ml per kg over half hour, 70 ml per kg over 2.5 hours, remaining so that the entire 100 ml per kg is given over 3 hours. Okay, let's summarize it. In plan A, the fluid is what? ORS. Amount is what? 10 ml per kg with each loose stool. No time point. Whenever loose stool, give it. Plan B, again you will give ORS either orally or NG. Amount is what? 75 ml per kg over 4 hours. Plan C is what? Plan C, you have to give IV fluids. Which IV fluid? The preferred is RL with 5% dextrose. How much? 100 ml per kg. How much? 100 ml per kg. This 100 ml per kg can be given over, this 100 ml per kg can be given over 6 hours if the child is less than 1 year, 3 hours if the child is more than 1 year. If the child is more than 1 year. Just one moment, let me take a little bit of water. I'm also having a little bit of dehydration. All right. Let's continue. Let's discuss maintenance fluids. Remember, a lot of people tend to get confused with maintenance fluid. I'll make it easy for you. Maintenance fluid have no relation to dehydration. What is this maintenance fluid? What is this maintenance fluid? It is a fluid required to maintain you. It is a daily maintenance fluid. It is the daily maintenance fluid. It is this. It is the water that you require on a daily basis. It is the water that the child requires on a daily basis. That is what is called as daily maintenance fluid. It has no relation to dehydration. It is the fluid which everyone will require on a daily basis. This is what is called daily maintenance. And this daily maintenance fluid is calculated by a formula called Holiday-Cigar formula. By a formula called Holiday-Cigar formula. This Holiday-Cigar formula says what? This Holiday-Cigar formula says for the first 10 kg, if a child is between 1 to 10 kg, the daily maintenance fluid is calculated as 100 ml per kg. Given in what? 24 hours. Like I said, it is daily maintenance fluid. If the child is between 11 to 20 kg, then it's calculated as for every kg above 10 kg. For every kg above 10 kg, then it's calculated as 50 ml per kg. Again, 24 hours. And any kg above 20 kg is calculated as 20 ml per kg. Again in 24 hours. I'll explain with the help of an example so that it becomes very easy. Let's say the child is 7 kg. For a 7 kg, the maintenance fluid is going to be what? It's going to be 7 into 100, 700 ml. 700 ml. Okay. If the child is 17 kg, so for the first 10 kg, it's going to be what? It's going to be 100 ml per kg. So 10 into 100 is equal to 1000. And for the next 7 kg is going to be 50 ml per kg. So 7 into 50 is equal to 350. You will add these things together. So the actual volume is going to be what? 1350 ml. So for a 17 kg child, the maintenance fluid is going to be what? 1350 ml in 24 hours. In 24 hours. And let's say there is a child who is 27 kg. Let's say there is a child who is 27 kg. Again the same thing. First 10 kgs. First 10 kg, 10 into 100 is equal to 1000. Next 10 kg, till 20 kg. Now you are going to give what? Next 10 kg is going to be 10 into 50 is equal to 500 ml. Right? And another 7 kgs are still left. So 7 into 20 is equal to 140. Now add these three things together. 1000 plus 500 plus 140. 1640. So this will be the maintenance fluid in a 27 kg child. So that's how you calculate maintenance fluid. That's how you calculate maintenance fluid. It's a daily fluid that you required. It is the daily water that you required. It is the daily water that you required. Okay. All right. What is the ideal maintenance fluid? Water. It is your water. In case the child is NPO, you're not giving orally. For example, he's scheduled for a surgery. Let's say the child is NPO. Then the ideal maintenance fluid is DNS. It is dextrose with NS. 5% dextrose with NS. If you're taking orally, then the ideal maintenance fluid is going to be water. It is a daily fluid requirement, the daily water intake that you require. Okay. If the child is NPO, then the ideal maintenance fluid is DNS. Now, one important GI surgical disorder, IHPS. Infantile hypertrophic, infantile hypertrophic pyloric stenosis. So what happens in this infantile hypertrophic pyloric stenosis? The name itself is telling you. Let's say this is a stomach. The pylorus, at the pylorus muscle, at the pylorus, what's going to be there? There's going to be hypertrophy. There's going to be hypertrophy of this pylorus. Okay, so there's going to be hypertrophy of circular muscle at pylorus. And if this hypertrophy of pylorus, whatever food that you take won't be able to go down. You will vomit it out. So how it will present? It will present with recurrent vomiting. Which vomiting? Bilious, non-bilious? Obviously non-bilious. Bile hasn't come at all. So it will present with recurrent non-bilious vomiting in the second or third week. In the second or third week. That's how usually it presents. Another thing, what will happen? The stomach will try to contract. It will try to contract to get the food. The stomach will try to get the food from the stomach into the intestine. This will result in what? This will result in visible peristalsis. This will result in visible peristalsis. Because the stomach will try to contract and you will be able to see. And along with that, this thickened circular muscle, sometimes you can see it visibly also. You will see visible olive-shaped mass. You will see a visible olive-shaped mass because of this thickened pyloric muscle. Most of the questions of IHPS are from the metabolic problems. Most of the questions of IHPS are from the metabolic problems that you might see. What are these metabolic problems? So if you are vomiting out everything from stomach, stomach has what? Stomach has HCl. You vomited out all the HCl. You will end up having what? Metabolic alkalosis. You will end up having what? You will end up having metabolic alkalosis with, usually they have metabolic alkalosis with paradoxical aciduria. With paradoxical aciduria. Why does this paradoxical aciduria occur? So you're vomiting out everything. What's going to happen to your volume status? Hypovolemia, right? BP will fall, hypovolemia. Whenever there is decreased volume in a body, what's going to happen is going to stimulate RAS. Right? Renin-angiotensin system, renin-angiotensin-aldosterone system. Whenever you have hypovolemia, whenever you have decrease in BP, RAS is going to get stimulated. What will this RAS do? What will this RAS do? In this RAS, you have this aldosterone. Aldosterone will try to preserve water. It will try to preserve water. How does it preserve water? It will go to kidney. In the kidney, it will try to preserve a lot of sodium. And with this sodium, it will preserve water. When the sodium comes, along with that, water will come. But if you're absorbing a lot of sodium, aldosterone will throw out. It will throw out what? It will throw out a lot of H+. It will throw a lot of H+ and K+. And this H+ and K+ will come into urine. One second. And this K+ and this K+ and H+ will come into urine. And this will result in what? This will result in paradoxical aciduria. This will result in paradoxical aciduria. Alright, so this aldosterone will try to preserve a lot of sodium and water at the expense of K+ and H+. The K+ and H+ will come into urine. H+ comes into urine. If you have H+, H+ is what? Acid in urine. That's why you will end up having this paradoxical aciduria. Audible? Now audible? Now audible? Just 1 second, just audible now? All right, I'll start again. I'll start again. All right. So, according to IMNC, you can have no pneumonia, pneumonia, or severe pneumonia. These are the 3 main categories. Okay. In no pneumonia, you'll have what? You'll have cough and cold. You can have plus or minus wheeze. Plus or minus wheezing can be there. But no features of pneumonia or severe pneumonia, obviously. Right? No features suggestive of pneumonia or severe pneumonia. What will be the treatment? Do you need antibiotics in pneumonia? If you don't have pneumonia, do you need antibiotics? No. Obviously, you don't require any antibiotics. So, no antibiotics. Only soothing measures. Only what? Only soothing measures, nothing else. If there is wheeze, if wheeze is there, then you can consider giving what? If wheeze is there, then you can consider giving salbutamol. Then you can consider giving salbutamol. Alright. Coming to pneumonia, actual pneumonia. Pneumonia is of 2 types. Fast breathing pneumonia and chest indwelling pneumonia. Fast breathing pneumonia or chest indwelling pneumonia. If there is chest indwelling pneumonia, that's very simple to understand. There is going to be chest indwelling. Simple. If there is fast breathing pneumonia, then you need to have fast breathing. That is high respiratory rate. So what is the cutoff for that respiratory rate? If there is, let's say, fast breathing pneumonia, then you need to have fast breathing. Fast breathing means high respiratory rate. So what is the cutoff for that respiratory rate? The cutoff for that respiratory rate is age dependent. For less than 2 months, for children less than 2 months, the cutoff is what? It is 60. For 2 to 12 months, it is 50. And more than 12 months, it is 40. That is the cutoff. So let's say a 6-month-old child, if he has a respiratory rate of more than 50, then you say he's having fast breathing pneumonia. As far as pneumonia is concerned, obviously now you have to give antibiotic. So you'll give what? You'll give amoxicillin for 5 days. And you'll ask the mother to follow up in 2 days. You'll ask the mother to follow up in 2 days. So this is as far as pneumonia is concerned. Either fast breathing, high respiratory rate, or chest indwelling. Either of this can be there. As far as severe pneumonia is concerned, in severe pneumonia, you can have what? Either there can be stridor. There can be what? There can be what? Stridor in a calm child. Stridor in a calm child. Or signs suggestive of very severe disease. Or signs suggestive of very severe disease. So what can be these signs which suggest that there is a very severe disease that might be there? These include your high grade fever, fall in SpO2, convulsions, that is your seizures, and poor feeding or lethargy. So if any of these signs will suggest that there is a very severe disease. So we'll automatically classify it as severe pneumonia or very severe disease. If there is a very severe disease, you cannot manage it in a PHC. In a primary health center, you cannot manage it. IMNCI was made from a primary health center management. You cannot manage it in a PHC. You have to refer. So you have to do what? You have to refer. You have to refer. After giving the first dose of IV antibiotic. After the first dose of, which can be ampicillin or gentamicin. Which can be ampicillin or gentamicin. Okay. So this is as far as IMNCI management of pneumonia is concerned. We come to the last topic, a little bit of cardio. These X-rays are very important. These X-rays are very important. This is what? Egg on string appearance. This is what? Egg on string appearance seen where? In TGA. Transposition of great arteries. Seen where? Transposition of great arteries. This is what? Figure of 8 or snowman appearance. This is seen in TAP PVC. Total anomalous pulmonary venous connection. This is a box-shaped heart. Box-shaped heart. This is seen where? This is seen in Epstein anomaly. This is seen where? This is seen in Epstein anomaly. And last is what? Last is this. Boot-shaped heart. Seen where? Tetralogy of Fallot. Seen where? Tetralogy of Fallot. The last topic I'll discuss, very important, tetralogy of Fallot. After that, we'll take a call it a day. And then I'll talk about some important topics that you can do a little bit on your own, which I have not covered, obviously, because I cannot cover entire pediatrics in 2 hours. The most important topics I've covered for your one shot, for your revision purpose. Last thing I'm going to discuss is tetralogy of Fallot, the 4 components of tetralogy of Fallot. Now, as far as tetralogy of Fallot is concerned, always remember the very first component of tetralogy of Fallot is this. The very first component of tetralogy of Fallot is this, that is your pulmonary stenosis. That the pulmonary artery is going to get stenosed, and this pulmonary stenosis is below the level. It's below the level of pulmonary wall. That's why it's also called subpulmonic stenosis. That's why it's also called subpulmonic stenosis. Now, what will happen because of the subpulmonary stenosis? The right ventricle wants to push the blood into the pulmonary artery, but the pulmonary artery is stenosed. So what will happen? The right ventricle will undergo hypertrophy. So there's going to be right ventricular hypertrophy. So there will be RVH. That's the second component. The second component, that there's going to be right ventricular hypertrophy. Now the right ventricle really wants to pump the blood into the pulmonary artery. It's not able to do so. So what it does? There is a huge VST. There is a huge VST. And the right ventricle starts to pump blood from right side into the left side through this huge hole, that is VSD. That is the third component. You have a large unrestrictive VSD. You have a large unrestrictive VSD through which there is going to be a right to left shunt. The right ventricle will start to pump the blood into the left ventricle. And if there is a right to left shunt, what will happen? You will have cyanosis. You will have cyanosis. Okay. And because there is a huge VSD, what happens? It appears that the right side of the heart and left side of the heart, the right ventricle and left ventricle, they are a common chamber. Alright. So normally it's going to be like this. There's going to be a right ventricle, left ventricle, there's going to be a ventricular septum. Right. This is going to be what? Aorta. In case of tetralogy of Fallot, what happens? There is a huge VSD, there is no ventricular septum. And it appears that the right ventricle and left ventricle, they are a common chamber, there is a single chamber. And this aorta now seems to arise from this common chamber. This is what is called as overriding of aorta. So this is the fourth component. So what are the 4 components of tetralogy of Fallot? First, you will have pulmonary stenosis. That will give rise to what? That will give rise to right ventricular hypertrophy. Right ventricle will pump the blood from right side to left side through a huge VSD. So this gives rise to the third component, that is huge unrestrictive VSD. And because the VSD is so huge, aorta will seem to arise from a common left and right ventricle. This is called overriding of aorta. That is the fourth component. So these are the 4 components. Overriding of aorta. So these are the 4 components of tetralogy of Fallot. These are 4 components which are very, very important to remember. Then important one thing, remember the severity of stenosis. Remember the severity of stenosis. So what is the genesis of this tetralogy of Fallot? It is your pulmonary stenosis. Pulmonary stenosis causes right ventricular hypertrophy that causes the right to left shunt. So everything will be dependent upon this pulmonary stenosis. Higher the pulmonary stenosis, more the right ventricular hypertrophy, more the right to left shunt. So the severity of the cyanosis and the timing of the cyanosis will be directly proportional to the pulmonary stenosis. Always remember that. Alright, they will be directly proportional to the pulmonary stenosis. Always remember that. Alright? Always remember that. So with this, we complete the today's one shot. So 2.5 hours, we have completed most of the important topics. Other topics that you need to do a little bit on your own, which I have not covered. Okay, which I have not covered, which I will say that you know. So one person rightly pointed out, neonatal resuscitation is one thing that you need to do on your own. And one important thing, familial short suture versus CDGP. That's it. From general pediatrics, I've covered most of the topics. Neonatal resuscitation, familial short suture versus CDGP. This is something which you can do on your own. Not too tough topics to understand, you can do on your own. From systemic pediatrics, what the things which you can do is, actually they were not systemic pediatrics, they are things which probably will be covered in pathology. Like for example, they have asked questions on leukemias a lot, but they will be covered in pathology, it will be covered in medicine also. So that's one thing you can consider doing. Nephrotic syndrome. Actually, as far as nephrotic syndrome is concerned, most of the questions are on one only. What is the drug of choice for nephrotic syndrome? Remember, it is steroids. Steroids are the drug of choice for nephrotic syndrome. What is the drug of choice for SDNS, steroid dependent nephrotic syndrome? It is your MMF. Remember that. What is the drug of choice for steroid resistant nephrotic syndrome? It is your calcineurin inhibitors. So these are the three things that I have asked. Let me cover the nephrotic syndrome for you also. A small thing that they have asked once. Okay, one thing that they have. And apart from that, from nephrotic syndrome are leukemias and lymphomas. And in neuro, in neuro you need to do management of seizures. That is your febrile seizures and your status epilepticus. These are the two other things that you need to do on your own. Most of the topics otherwise are done. Most of the topics, important topics are done. If you've done this one shot, be rest assured you can answer at least 60 to 70% of the questions correctly. At least 60 to 70% of the questions correctly. IgA, PSGN बता दीजिए. ठीक है, एक बार बता देता हूँ, बोलने में क्या है? PSGN, name itself is telling you. Let's just discuss what is happening in PSGN. Someone is pointing about that. Let's just discuss this. PSGN versus IgA. First is cause. Okay, PSGN versus IgA nephropathy. PSGN versus IgA nephropathy. PSGN is what? Post-streptococcal glomerulonephritis. You will have a streptococcal sore throat. Antibodies will form against that streptococcus. That antibodies and the streptococcus will form immune complex. That immune complex will get deposited in the glomerulus. That will cause hematuria. That is PSGN. So what is the cause? It is immune complex deposition. It is immune complex deposition. IgA nephropathy. IgA will deposit in mesangium. That's it. IgA deposition in mesangium. PSGN. Once it occurs, that's it. If the child recovers, child will be fine. So there will be no recurrent hematuria. Single episode. While IgA nephropathy, this IgA can keep, it's a genetic disorder, keep on occurring again and again. So there's going to be recurrent hematuria. There's going to be what? Recurrent hematuria. If PSGN occurs only once, will there be long-term damage to kidney? No. No long-term damage. Here, obviously, there's going to be long-term damage. So it can progress to end-stage renal disease as well. Coming to treatment, in PSGN, as far as treatment is concerned, is going to be supportive. Is going to be what? Supportive. While as far as IgA nephropathy is concerned, you have to give ACE inhibitors. You have to give what? ACE inhibitors. You have to give ACE inhibitors. So that's it. Those are the most important differences in PSGN. Post-streptococcus. Streptococcus infections, either a sore throat or skin infection, that forms antibodies. Those antibodies plus streptococcal antigen forms what? Immune complex. That immune complex gets deposited in the glomerulus, causes hematuria. IgA nephropathy, IgA deposition causes hematuria. Both will have hematuria, both will have glomerulonephritis, but IgA nephropathy, it will be recurrent. In PSGN, the immune complex, it will not be recurrent, it will occur only once. Occurs only once, no long-term damage, treatment is just supportive. IgA nephropathy, you need to give ACE inhibitors. That's it. Otherwise, like I told you, these are the other topics that you need to do. Neonatal resuscitation, do that. Familial short stature plus CDGP, please do that. Systemic pediatrics, leukemias, nephrotic syndrome, seizures, and yeah, cystic fibrosis. Cystic fibrosis is another thing, but I think that must have already been covered either in medicine or in path, you must have done it. That's it. These are the important topics that you need to do. Apart from that, most of it is done. All right, that's it. I'll call it a day. It's already going to be 12 o'clock. Happy New Year to every one of you. I hope every single one of you passes. Don't lose hope. All of you have worked hard. Stay calm, stay positive. Thank you.